held in Intercontinental Hotel Riyadh, but there are some speakers who will join us virtually. Well, yours truly is one of them. And we are on live stream through YouTube. As yesterday, day one was a successful event, and hopefully today we will have the same outcome. A very warm welcome to all the SSBMT board members, to Dr. Ahmed Alaskar, the SSBMT president, and to Dr. Ana Sereda, for the EBMT president. The president of the EBMT nurses group, Ms. Michelle Kenyon. I also welcome all the eminent speakers, moderators, and distinguished guests from all over Saudi Arabia and Europe. I would like to thank our generous main sponsors, Astellas and Sanofi. Let us also acknowledge the hard work of the organizing and scientific committee, the public relations team, and of course, the event management team, headed by Ms. Noor Kaya, for ensuring the conference will run smoothly as planned. Today's conference is divided into 3 sessions. We have 13 speakers that will share their valuable knowledge and vast experience with hematology, HSCT, in relation with a nursing perspective. And I hope that this meeting will add us more insight on the different practices and latest trend in hematology, HSCT patient care. Feel free to ask your questions related to the presentation at the end of each session. And for those who will watch via YouTube live stream, you can also drop in your questions in the chat box. Once again, my name is Annalise Stanislao, SSBMT Nurses Group President and an adult nurse coordinator from King Fahad Specialist Hospital, Dammam. Now I will give the floor to Ms. Michelle Kenyon for her welcome remarks.
Anna. I'd just like to say a huge thank you to the SSBMT committee and organising team for, again, inviting us as EBMT to join in this fantastic collaboration. It's hard to believe that the meeting is now in its 9th year, and last year was the first time that I was involved with this meeting. And of course, we were holding the meeting as a virtual conference, but still the energy and the educational content of the meeting was absolutely excellent. And I hope that today we can deliver for you a sort of equally brilliant programme. I just want to take the opportunity to tell you a little bit about the EBMT Nurses Group. So it's just a brief introduction to me. I'm the current president of the EBMT Nurses Group, and I work as a consultant nurse in transplant in the United Kingdom, having previously worked as a nurse on the transplant unit, and then as a transplant coordinator, and then as a post-transplant nurse specialist. So I have worked through all of the roles along the patient pathway, so feel fairly informed as to how that all works. My current role, I have a clinical, academic and a leadership role, and that really plays to my interests in supporting nurse development, being interested in the psychosocial needs of our patients, and also late effects and survivor care. And I'm very lucky to be able to speak to you a little later on about my experiences in survivor care and late effects, and also present a couple of abstracts from the EBMT 22 meeting. I'm a registered nurse with a degree and a master's, and I really have a passion
Recording in
for
progress.
hemato-oncology nursing research, as well as education and development. And I'm very fortunate to be able to deliver some of those things in my role with the EBMT. Just a little bit about the EBMT Nurses Group. We have a mission to enhance the value of the nurse's role all over the world, and we deliver that throughout the work of our EBMT Nurses Group committees. We support and share knowledge through communication, advocacy, research, training and education, and we work very closely with our Patient Advocacy Committee to try to ensure that our projects are in line with helping to meet the needs of our patients. We share the vision with the EBMT Society, of course, to connect between patients, scientific community, and other stakeholders to anticipate the future of our field. This is our board. We have two members of our board, myself as president and Daphne Hutt, who is the EBMT Nurses Group's secretary. We would have a past president and a president-elect, but this year it is just the two of us. This is an organogram of our nurses group, and you can see we have committee representation. We also have JC committee representation as well as the scientific committee, research committee, pediatric committee, and our global education committee with our working party nurses. So each of the working parties, the EBMT Society, we have a nurse representative on there as well, bringing the nurses research agenda to the working party. And we also have 10 active national groups that are affiliated with the EBMT Nurses Group, and we get together once a year at our International Study Day and Research Study Day as a big group, which is a fantastic way to share. Just a quick word about our growth and our reach as a nurses group. We have almost 1,000 nurse members across 53 countries worldwide, with a principal nurse identified in almost every EBMT centre. And you can see there a summary of our education activities throughout 2019 to 2021. We have undertaken a massive project in 2020-21 with LABMT, and that was led by my colleague Eugenia Trigoso as part of the Global Education Committee work. And we also put a couple of COVID-based webinars around nurse support and self-care during the COVID pandemic. We've produced a textbook for nurses that was published in 2018. We're currently working on the finalised manuscript of our next second edition. It's free to download, and so far we have downloaded over 444,000 copies, which is quite an immense achievement and really in the spirit of collaboration of the EBMT. We will translate the second edition into French, and we hope to launch that at the annual meeting in 2023 in Paris. Quite a lot of e-learning resources. We're active on Twitter, and we also have a number of publications in peer-reviewed journals. Thank you. I'd now like to hand over to the first speaker.
think they are the success of any transplantation program, especially with the new move toward cellular therapy. Forward. Okay. So if you go through the program of EBMT 2022, it's not moving. Why? You will see the nursing program is the largest, and they had 23 sessions compared to other, and so the indication of transplantation in recent years has expanded, and that's led to not only in the number but also in the type of transplant, or I would say cellular therapy. So the CAR-T, as you saw yesterday, there was a complete whole session about CAR-T, and CAR-T has nothing to do with the stem cell transplantation. And it's another type of cell that we get from the patient, we manipulate genetically, and we expand it ex vivo, and we return it to the patient. So it's very important to understand how these cells are made. It's an introduction to the nursing group. And honestly, when I attended last year, this year I was going to attend, but then the war in Ukraine, really, they canceled the physical meeting and they made it only virtual. So I usually go to the nursing meeting because they are first very educational. You see the A to Z understanding. Unlike the physician, they present the study, middle of the study, and there is graph up, graph down, progression-free survival, overall survival, things that doesn't explain the basic science of how things are being done. I spoke yesterday to the president of EBMT. I was honored to see her, Prof. Anna, and I told her when the EBMT will change their names. The American already changed their name from SSBMT to American Society of Transplantation and Cellular Therapy. It's a very important component. And she told me that there is a board meeting and she will discuss this issue. Then I saw Dr. Al-Askar. I told him, when you are going to change the society name SSBMT, it's old-fashioned. He said, after EBMT, if they change, we will change. If they will not change, we will not change. Because it's a heritage, it's like something from the past. But in my hospital, the name of the department changed from hematology and HSCT to hematology and TCT, transplantation and cellular therapy. It's very important. Maybe in King Faisal, they have the CAR-T, and they really should match, but all transplant centers should match the trend toward the move to meet the new areas of transplantation. So talk this. So my presentation is basically going to the basic of how to do the CAR-T. My master was cellular therapy before. It was in the last century. This was about 23 years or 24 years, where my thesis was on getting T-cell, isolating gamma delta, expanding ex vivo gamma delta, and return it back to the patient. So it is like CAR-T, they take T-cell, except I wasn't doing genetic modification because the gamma delta, they have the capability, they don't need education. They are very well-educated cells. So that was the purpose, but then the molecular targeted therapy came and I didn't complete the cellular therapy. Anyhow, 20 years later, it's there. So to our nurses, be ready. You are our partners of success. And as it was said by Ed Thomas, the father of transplantation, nurses are the success of any transplantation. I will say nurses are the secret of success, because everyone is claiming that they are the success. Yes, it's a teamwork, of course, but if you want to know the secret, because, we physicians put the order, and then who will take care of the patient? Who will recognize the cytokine release syndrome or the ICANN or all toxicities of cellular therapy or transplantation? Nurses. They are 24 hours with the patient. Physician, we can calculate how many minutes or sometimes hours if the patient's sick, but it's very few. So we really need to have strong nursing, education, collaboration, and putting the basics together. Gene editing is the method. So I was talking in Harvard, they had the course. It's called CRISPR-Cas gene editing. And how they are doing the CAR-T, so chimeric antigen receptor. So it's important to know from where this came, what's CAR-T, and that's what I did in my hospital. I did grand round about CRISPR-Cas, and then I talked about gene editing, and then I talked about the CAR-T. I have no conflict of interest here. So what's the CRISPR? The CRISPR is a method that the prokaryotic, the bacteria, will enable itself to fight the virus, the bacteriophage. So, the bacteriophage will attack the bacteria and use its DNA to multiply. So I'll go to the picture here. So this is how the bacteriophage attack the bacteria, inject its DNA. DNA is replicating, and now they end up with the bacteria dying, and the bacteriophage is multiplying. The bacteria, they have the mechanism of CRISPR-Cas9. What's CRISPR-Cas? So it's clustered, regulatory, interspaced repeats of using endonuclease to cut the DNA of the virus and prevent virus replication. So it's a gene editing. You cannot see what happened in the down, that the virus, the bacteriophage enter into the bacteria. Bacteria already, they have the CRISPR-Cas, they cutting the DNA, put it aside, the bacteria survive. And the beauty of this gene editing, that it's inherited. I mean, it's transformed from one generation of bacteria to the next generation of bacteria. Unlike we give chemotherapy, it's one dose. You have to give repeated doses. But CAR-T, you give the cells. These cells can multiply and replicate, and they can stay in the system 3 months, 6 months. So whenever there is chance for the disease to come back, they are there. So they are very efficient in eradicating the disease. So that's how we learned this lesson from bacteria. We took it into human. And by the way, gene editing has been in practice for years. It was this century, second decade, that they had the introduction of clinical, medical use of CRISPR-Cas or gene editing. But it was before in this, the farming, the agriculture, the animal breeding, they use gene editing. So they have the rice, there is gene editing, so these rice crops will have resistance to any parasites or infestation. So they have large amount of production. And in industry, in many things, it has been in our life. Lately, it came into medical. And you can see the benefit of having this gene editing. So now we will talk about the embryonic. Embryonic, of course, we are not allowed to do any research. So the scientists, they discovered the induced pluripotent stem cell, and that's how so you can take embryonic from the blastocyst, or you can have induced pluripotent stem cell, and you can get whatever cells you want. And then you can do gene editing with these cells, with whatever, and reintroduce to the patient. So here, beta thalassemia is very excellent example of successful gene editing using the CRISPR-Cas. Yesterday they talked about sickle cell. I didn't attend, but it wasn't successful as beta thalassemia. Beta thalassemia now is an approved indication of therapy in patients with beta thalassemia measured as a cure. Transplant is one area, but the gene editing is another area. And that's what they do. They have the patient with the genetic disorder. They take the cells and they convert it into induced pluripotent stem cells. They have the genetic defect. They repair it with the CRISPR-Cas gene editing, and then they differentiate and then return to the patient. Beautiful. Beautiful method. It's peaceful. Of course, gene therapy, there is conditioning still. So we cannot live without nursing. So no dream. It's not as simple because there will be admission. Patient should be fit for receiving conditioning in order to be able to accept these newly modified, their own cells. So that's the genetic editing and where it will lead us in treatment of diseases. CAR-T is a new therapy. We have to be careful with anything new. We really need to monitor. So among the challenges is off-target effect, meaning you do gene editing, but you don't know what's the function of this gene. So what are the consequences? That's one part. Another part, making sure that it is giving the target that you are aiming to. Another risk is the P53. So Allah subhanahu wa ta'ala created in our body a very efficient mechanism. Anytime you have the cells, the gene manipulated, there is a gene called P53. It will be activated and this cell will die. So in order to overcome this P53 mutation effect, they induce offsetting or silencing of this P53. So CAR-T, they are dividing, they are giving the target that we wanted, but without P53 on board. And when you lose P53, which is a secure mechanism against any mutation happening, so we should monitor all patients receiving CAR-T, even if it is their own cells. We really need to be careful. It's very effective, as we saw yesterday, but it has to be done with long-term monitoring, making sure that we are not getting some of the unwanted effects. So that's the P53. Germline, in human, we shouldn't touch. That's a principal ethics now. Gene editing is there, but germline, we should not. So what happened in China, there was a scientist there was a person who had HIV, and he wanted to have offspring without HIV, which is possible. I mean, there is the AZT they can use during pregnancy, etc. But he wants his offspring, the IVF product, to be resistant to HIV. And we know that CCR4 is a receptor that, if present, these cells will be resistant to HIV. So he went to the scientist, he introduced this CCR4 into the fertilized ova. So now we are manipulating the germ line. And he was successful to get offspring, 2 daughters, IVF. They are resistant to HIV, but the ethical issues came after. And I was attending ASH 2018 annual meeting, and this had a hot discussion. How come we allowed this to happen, germline? And what I heard lately, that he was captured and he's in prison and he will be for decapitation. Very strong punishment. I don't think it should be this way, but there should be ethics to handle. So germline we should not touch in a human. And then what they are after in the future, that we can now get like gene editing from allo, like you don't need to have the patient. Sometimes we have problem of getting the CAR-T from the patient. So now what they are after, universal CAR-T. Because if you gene edit HLA typing or presentation on the cell, So you can have a cell without HLA typing or antigens, and with the gene editing effect, you can return it to the patient with what you want to get the effect. So there are lots of changes. Of course, the use of CRISPR in diagnostic tool is well established, and the therapeutic use of T cells, that's the usual T cells from tumor infiltrating lymphocytes. This was last century. They take the T cells from the tumor, so they have the tumor with T cells, they extract T cells, and then they expand it, return it. There's no gene editing. That's what's happening with CAR T, the same. There's tumor, there's T cell, they take the T cell, they edit it to be effective only for the tumor-targeted cell and return it to the patient. So that's the method change. And by the way, CAR T is not only for malignancy. So anytime you have something you don't like, so if it is physical, you can ride your car and hit the person. Or if there is a disease, you can create a CAR T, chimeric antigen receptor, against, let's say, a patient with hemophilia inhibitor. The cells producing the inhibitor is B cell. So you can develop a CAR T against the specification of the B cell and get rid of the inhibitor instead of using these bypassing agents and all these dilemma we are getting with it. So all diseases, not only hematological malignancy, aging, multiple sclerosis, all neurological, different disease. Define what target you want, develop a specific CAR T, and hit back. So that's what's happening. So universal CAR T using multiplex CRISPR-Cas9, and then you can use also the animal as a tool. So let's say this patient had, she needs a pancreas, you can take induced pluripotent and you can put it in the blastocyst of this chimeric blastocyst and return to the pig. Pig will have the pancreas with human cells, and then you can take the pancreas transplant because it's from the same patient. So there are many advances in this cellular therapy. So nurses should be aware, and their knowledge, basic science knowledge, better than physician. And that's other application is reconstructive, regenerating the hearing ability. You can imagine anything missing, you can reintroduce it through gene editing method. And that's my last slide, and thank you very much.
Thank you very much, Dr. Bassem. Really, thank you for the first few minutes that spent that encouraging the nurse and appreciating their partner in the care. It's very clear your passion in the cellular therapy. We understand now why you changed the name of the department to be with. Thank you very much, appreciate it.
Okay. Allow me to introduce our second presenter for today, Ms. Michelle Quignon, Dr. Michelle Quignon. She's a consultant nurse in blood and transplant, BMT, with interests focused on improving the patient and caregiver experience of hematopoietic stem cell transplantation and supporting patients throughout their post-transplant recovery. Her research and service development interests center on patient experience, psychosocial issues, treatment complications such as GVHD and VOD, and consequences, and the unmet need of those living with and beyond their diagnosis. Her role also enables her to lead a team and teach regularly. Michelle is current president of the EBMT European Blood and Marrow Transplantation Nurses Group. She has authored 2 patient information books, which are used as the basis of informed consent for transplant recipients throughout the UK, and co-edited the first EBMT textbook for nurses published in 2018. Without any further delay, please welcome Dr. Michelle.
Thank you so much for your kind introduction, and thank you again. It really is an absolute pleasure to be here, and thank you for inviting us. So we have, as this session, the long-term follow-up, and then the following session will be short-term follow-up. So we have these slightly in reverse, so please bear that in mind when listening to this session. There will be more to come that fills in that gap. So I want to start really by just giving you a brief outline of my session. So really just thinking about the definitions, what is long-term follow-up care? When do patients reach that point in their journey? Why is it important? Why do we need it? Why should we care when patients are cured? What the risk factors are that influence the trajectory of the long-term follow-up. I'm going to set up and lead in my hospital, King's College Hospital in London. And then I'm going to just introduce you to a couple of the abstracts that were presented at EBMT this year that relate to long-term care. So a couple of definitions, sorry, a lot of words on the slide, but a long-term survivor is generally people who are reported to be alive and free of their disease at 2 years after transplant. They're called long-term or disease-free survivors. And survivorship itself is a rather nebulous concept. There are various definitions. People often get this wrong. It's not about being alive at a certain point, but it encompasses not just living past the milestones of day 100, 6 months, 1 year, 5 years, but also the expectations of a return to some physical and mental well-being and the continuation of the pursuit of a normal life or meaningful life. It recognises that each of our transplant recipients will have very different complications, different expectations depending on their context, and they'll also face different challenges and triumphs along the way. And I think we can all identify with that concept of survivorship when we think about our patients that are recovering and in that zone. So just thought I'd provide some numbers really to give you some context around some of the problems actually that we face with our survivor population. We've actually got quite good at looking after people post-transplant, so much so that the number of people that are living beyond those first few months and first few years is increasing, and that does pose a problem for us when considering service development and service growth for our survivors. So the number of transplants is increasing year on year. That's that top graph there. And then the bottom graph there from the 2019 data of CIBMTR shows the number of people in follow-up according to the years and ages. And you can see that that is increasing. So the drivers for this are increased transplant numbers. Our reduced intensity conditioning regimes have meant that we can transplant more people safely. We get them through that first bit of the transplant phase, so we have a much better chance of being able to look after them in the longer term. Having access to a whole variety of cell sources, so effectively there's a donor for almost every single patient now, so managing to find a donor isn't really a limiting factor, so much so as it was maybe 10 or 20 years ago. And we're also gathering new indications for our patient population. So with autoimmune diseases and indications like sickle cell transplant coming nicely through to the adult setting. We also have better supportive care. So we're much better at looking after our patients. We're better at anticipating organ damage, our infections, and our severe graft versus host disease. So we know that the immediate survival after transplant's no longer enough. Our patients expect more from us, and that's correct and right. Our goals should now include a complete recovery of the health status with as near normal as possible physical and psychological or psychosocial functioning, normal family and social integration, and good subjective well-being. So we want our patients to tell us that they feel well after the transplant, and this is not just about having a normal blood count or being free of leukemia or having controlled graft versus host disease. But we know that the mortality is 4.9 times higher than the age-matched peers in the general population. our patients are 2 times more likely than their siblings to develop chronic conditions. They're 3.5 times more likely to develop severe life-threatening conditions, and that is 4.7 times more likely if they have chronic graft-versus-host disease. More than 95% of our long-term survivors report the need for medical contact, and the need for physical examination increases over time. So we need to continue to look after these people year on year, lifelong. And we know that actually there are a number of major risk factors for late effects, and really we should start planning for long-term care at the time of transplant or before transplant, when we start to accumulate and acquire knowledge about our patients as individuals through their pre-transplant workup, through our knowledge of them as individuals and as people with aspirations and hopes. So there are 5 major categories for late effects: patient factors, disease features, the conditioning regime that we select, and whether we can minimise and mitigate some of the toxicities of that. The graft source will also play a role in how our patients fare in the long term, and the presence or absence or severity of graft versus host disease. So this slide, I won't read it through, but we have some common late effects and their risk factors listed here. As you can see, there's a huge list, and the list of risk factors on the right-hand side really tells us that it's quite hard to avoid at least some toxicity associated with the transplant. And how those toxicities will play out in the longer term is very much down to our surveillance as practitioners and the other risk factors that our patient might bring to treatment. But some patients will develop many, and there's a huge need for our ongoing surveillance to be individualised and personalised, because for all of our patients it's critical to be able to do that and make those facilities to limit. So I don't expect you to really be able to see this in any huge detail, but this is a schema that's based on the Majale guidelines from 2012. And if you look around on kind of CIBMTR and EBMT websites, these are the guidelines that are pretty much still dictating how we run our long-term surveillance, our late effects clinics. But obviously they're getting pretty outdated now. They're 10 years old or more, certainly published in 2012, and we're now obviously in 2022. I understand that the next iteration of these is perhaps 3 to 6 months away from publication, so we eagerly anticipate those because that will have an impact on some of the surveillance that we're currently doing. I understand that some of the investigations will be recommended to be undertaken a bit more frequently, and there'll be additional investigations as well. Things like metabolic syndrome, we understand a lot more of that about that now and its major role in long-term trajectory than we did probably 10 years ago. And I think that serves as a really good example for how we need to see some more updated guidelines. But this essentially gives some guidance on the frequency of testing that needs to be undertaken 6 months, 1 year, 10 years, and the testing that we should be doing annually. So, for example, it's not necessarily critical to undertake bone densitometry every year if the patient's bone densitometry is normal when it's checked and they haven't acquired any new risk factors for poor bone health. Then you don't need to keep exposing your patients to further densitometry. Things will crop up potentially during their lifetime that might encourage you to order additional investigations, but it's not necessary otherwise. So this is just an outline of the way that we run our long-term follow-up clinic at King's College Hospital in London. Referral criteria: our patient needs to be in remission. They can have graft versus host disease, but it's generally stable or absent completely, and no ongoing disease treatment, aside from TKIs. They're referred in at 12 months, and then they're seen annually in the long-term clinic thereafter for the rest of their lives. The minimum frequency of reviews in the first 1 to 5 years will be biannual, so they'll have an annual review in the long-term follow-up clinic with other reviews in our general post-transplant follow-up clinic. So they'll be seen at least twice a year. And in the long-term follow-up clinic, we're implementing the screening guidance, again, based on the Majel guidelines. I'll show a slide of our screening report in a moment. We also undertake holistic assessment, so all of our patients are encouraged and invited to complete a holistic assessment. It's a multi-domain assessment, very much like quality of life, where they self-report any psychosocial issues that they're experiencing, and then we're able to address those in the context of the long-term follow-up clinic, and they complete that online through a hyperlink before their appointment, so we can walk them through that when we see them, either in person or the way we have been the last 2 years is over a telephone or video consultation. We offer a lot of patient information and signposting as a result of the sort of consultation conversation and also as a result of the holistic assessment. And we play a huge role in helping to modify the health behaviours of our patients in this clinic, either in response to some of the blood parameters and values that we see, or through the conversation, or based on baseline values like their blood pressure or their weight. And at this time, we make any additional speciality referrals, maybe to menopause clinic or erectile dysfunction for our patients, or to psychotherapy, etc., and also all of the other specialists like dermatology, cardiology, respiratory, if we're finding anything at these time points. And we also start to increase the primary care support. So, as we all know, primary care physicians are often not involved. We keep them at arm's length for quite a while, certainly before and after the transplant, but it's really important that patients are able to access care for their basic needs closer to home. And so primary care does have a very important role in being able to deliver this. At 5 years, if all is well, then they're discharged from the routine post-transplant follow-up clinic and they're just followed in the long-term clinic alone. And that's just an annual review. And at that point, we're sort of kind of really phasing in patient empowerment strategies. So really encouraging our patients and equipping them with the tools to be able to advocate for themselves, to be able to articulate to primary care when they have a small problem, to know when to get in touch with us in between their annual reviews, because of course things happen in the meantime and we don't want our patients to save all their problems up just for the annual review. It may be necessary to fast track the patients back into our regular post-transplant clinic for any interim care or consultations that they might need. And then the rest of the care is pretty much the same year on year. This is our clinic report. I'm not sure how clear that comes up, but now there's a pointer on here, I think. I can't work it, but it doesn't really matter. So we do vital signs, observations, full blood count, all of the other kind of blood parameters as per the guidance. You can see there normal pulmonary function testing done in 2017. This is a patient who is 18 years out post-transplant, no new respiratory signs. We don't do another lung function. We have this corner and lifestyle kind of validation questions, essentially. So if the patients haven't really articulated anything on the holistic needs assessment, then this is our opportunity to kind of ask them outright, you know, how things are going with their weight, you know, and have a kind of weight management conversation with patients. If having an exercise conversation, talking to them directly about sexual function, and often our patients will find it quite difficult to talk about sexual function. Of course, that's a whole other talk. That's not the one I'm here to do this morning, but it's quite important that we have an opportunity to ask our patients, so that as we often feel uncomfortable as clinicians, our patients will often feel uncomfortable talking about it. So validating that, giving that problem issue airtime. We also talk to our patients about alcohol and smoking and use this as an opportunity to have a brief kind of targeted conversation about some of those lifestyle issues. For the medication, it's also important to ensure that what the patients are prescribed, they are actually taking. And again, you know, sometimes primary care physicians will adjust dosages of some of the medications, so we put these back on track when we see the patients in the clinic. Having a problem forwarding the slide. There we go. So these are just a couple of abstracts from the 2022 meeting. So this is quite interesting. It's a kind of patient-reported and proxy-reported outcomes among some pediatric allogeneic transplant recipients for non-malignant disease. And the title that they use, the strap, is "What doesn't kill you makes you stronger." So it's a single-centre cohort study looking at patient-reported outcomes, which were evaluated between December 20 and March 2021. Patients are more than 2 years after a paediatric allo for non-malignant disease, and they used age-appropriated patient-reported outcome measures. Patients that were more than 8 years completed their own, and less than 8 years, they were completed by proxy, so usually a parent. And they used validated tools to do this, and then, as you can see, the analysis. So the results are quite interesting. They had 119 patients participated, which is a reasonable number actually for self-reports, with a median age of 15.8 years, and about half of the patients, well, more than half of the patients were male. You can see a fairly even disease split across inborn errors, hemoglobinopathies and bone marrow failures. And you can see, again, a sort of a bias towards triasulfan and busulfan, with cyclophosphamide-based regimes taking up the smallest proportion. There were significant lower scores in the patient-reported outcomes compared to Dutch population, and physical health for children between 5 and 7 years in adolescents, and also reductions in psychosocial health for adolescents and school functioning for children aged 5 to 12 and also adolescents. But the young adults, the 18 to 30 years, reported no significantly different scores, which is quite interesting. So their conclusions were a normalisation of long-term reported outcomes in patients after paediatric transplant for non-malignant diseases in many of the domains, but more attention was needed for physical health, school and cognitive functioning, and that children and adolescents seem to be the most vulnerable, indicating the need for early supportive care to prevent long-term impaired quality of life. My second abstract is on a randomised trial of the impact of virtual-based multimodal training programme on physical fitness and quality of life in patients late post-transplant. And this abstract from Australia was really looking at the impact of exercise on reduced quality of life in transplant survivors. And so they wanted to look at physical training and psychotherapy intervention, and using an audio-visual platform to do that. So their study just reported the 3-month outcomes following a multi-centre randomised controlled trial of virtually supervised combined modal training. So I've put in an algorithm here just to show the randomisation. So patients were consented in an in-person introductory session to either the control group or the intervention group. Control group were instructed to maintain their usual activities, and the intervention group received instructions plus a weekly physical training and mindfulness-based stress management for 6 weeks via a video consultation. The assessments for both groups were done pre-training at 6 weeks and 3 months, with a primary endpoint looking at the 6-minute walk test and some other secondary physical, quality of life and psychological measures. So you can see the eligibility include people that were more than 18 and more than 6 months after transplant, and they had to have basic computer skills to be able to utilise the platform. They didn't include people with severe graft-versus-host disease who arguably might have benefited from this intervention. and they didn't include people with understandably exercise-limiting cardiovascular disease and severe anxiety or depression. Patients attending 4 of their clinics were invited, and you say consent was done in person. So they had 139 of 219 responders who participated, and it was a one-to-one randomization with patients actually a median of 21 months post-transplant. So a fair way out, almost 2 years. Median age is 58, and 25% of those patients lived more than 50 kilometres from the transplant centre, which would really have mitigated them from or excluded them from an in-person intervention. No real significant differences in the intervention and control groups concerning the variables mentioned there. So when you look at the consented participants of 139, the number that completed all of the assessments through the whole trajectory at pre and 6 weeks and 3 months, in the control group 128 and 130 in the intervention group. In the control group, the physical therapy and mindfulness-based stress management logins remained static, and the 6-minute walk test improved from 464 to 501. However, for the intervention group, the logs for physical therapy and MBSM increased over time, and the 6-minute walk test increased from 463 to 549. The intervention group favoured in 30-minute stress test and DAS depression and HADS anxiety as well, strength test, sorry. So for their conclusions, their 6-week virtually supervised intervention group improved with their physical fitness and their strength with the 6-minute walk test and strength testing, and also for their mental health for anxiety and depression. Interestingly, improvements in the 6-minute walk test and strength test correlate with increased functional capacity, and an over 50-meter increase with the 6-minute walk test is shown to correlate significantly with functional capacity and health outcomes. So the intervention group had a significant improvement. So they concluded that the virtual-based training program demonstrated benefit to transplant survivors in their own homes. I think it's a fantastic piece of work that they conducted there. And so with this, I just want to thank you for your time and for listening to this presentation. We have our transplant complications working party for anybody who's interested in late effects and long-term follow-up, and that is happening in September 2022 in Berlin. And we also have our transplant EBMT textbook for nurses with the hyperlinks there for both of those resources. Thank you.
Thank you very much, Dr. Michelle. Question and answers will be at the end.
Welcome, Ms. Amani. Ms. Amani Al-Harbi obtained Bachelor Science of Nursing from King Saud University for Healthcare Science. Ms. Amani currently, she's a post-stem cell coordinator in King Abdulaziz Medical City, Ministry of National Guard Health Affairs. Also, she is active in participating in a number of awareness campaign and volunteering work. Without any further delay, welcome Ms. Amani, please.
Good morning, everyone. Today, I'm going to talk about the post-stem cell transplant care in short term, means less than 1 year. First of all, my outline will be, this one? Sorry. Okay. Sorry. Yes, sorry. My outline will be, I'll talk about the post-allogenic and autologous care in our center and engraftment and the chimerism test. What is the calcineurin inhibitors and the drug levels that we should monitor? The most common infections post-stem cell transplant and most common complication post-stem cell transplant to monitor. And just briefly about the vaccination. So patients undergoing stem cell transplant, especially the allo transplant, they will be at risk of developing complications related to means like history of infection, like he have CMV reactivation before, during and post stem cell transplant. The resulting of morbidity of the stem cell transplant process makes it necessary for the patient to adopt a healthy lifestyle that promotes health and contemplate preventive measures for the detection and treatment of possible complications. And I'll just want to show you something from day 0 until day 30, patient will be at neutropenic phase, and in this duration, he will be prone for infection and he will be prone for very serious complication. So usually this period, he will be in ward until the patient gets stable, then he will be discharged to be followed by the outpatient clinic. And this is when the outpatient clinic works what is the role of SCT clinic? The regular and systematic screening, seeing patient for urgent issues, education about healthy lifestyle, and even foods, the meals that they have taken, evaluation of a new patient referred for stem cell transplant. And the monitoring should be multidisciplinary team. So the SCT team will be consisted of physicians, stem cell coordinators, SCT nurse, clinical pharmacist, dietitian, psychologist, and even social workers. I'll just talk briefly about our center. This is the approved disease indications are performed in our center. For autologous, is multiple myeloma, Hodgkin lymphoma, non-Hodgkin lymphoma, multiple sclerosis, and germ cell tumors. For allogenic, sickle cell disease, acute leukemia, bone marrow failure, aplastic anemia, chronic leukemia, myelodysplastic syndrome, and lymphoma. For the post-autologous stem cell transplant care, from discharge until day 100, first of all, one of the criteria to be transplanted that the patient must live near to the hospital, like maximum 1 hour far from the hospital, just like in case that he have any urgent issues, so that he can reach the hospital very fast. To be seen once weekly for the first month, then if the patient is stable, to be seen once every 2 weeks for 3 months, and then once a month from 3 to 6 months post-SCT. Clinical evaluation and transfusions when necessary. Maybe the patient needs electrolyte replacement, blood transfusion in this period. Basic hematological and biochemical tests, like for in day 90, we'll do the disease assessment for the patient, like multiple myeloma, we'll do the biochemical tests like free light chain and kappa and lambda. Specific markers for different diseases, like for CML, PCR, ABL, every 3 months, to start consolidation and maintenance therapy as indicated. For example, for Hodgkin lymphoma, we'll start like brentuximab, 16 cycle. At 3 months and above, until 1 year, we should to evaluate the status of a primary disease, like hematological and biochemical tests, specific tumoral markers, MRD evaluation, immunophenotype, and molecular specific adapted to each disease, bone marrow biopsy in case of non-Hodgkin lymphoma, Hodgkin lymphoma, and solid neoplasm in a previous marrow affection, imaging test depending on primary disease, like for Hodgkin lymphoma, BAN-CT, BET-CT, and start vaccination from 6 months. We will talk about it later. For allogenic transplant, to be seen differently, like 1 to 2 times per week for the first 1 month, then once or every 2 weeks till 3 months. If his patient is still stable, like there are no signs of GVHD or infection and no signs of pulmonary complication, to be seen monthly, 3 to 6 months. Each visit, we will check the CBC, liver and kidney function, magnesium, and quantify the CMV, PCR, and EBV, because patient will be at risk of getting infection. So CMV and EBV, PCR weekly, unless that patient is have real infection. So it will be, after initiating the treatment, it will be checked twice weekly until he gets negative. Bone marrow aspirate and biopsy in disease previous marrow affection. As I said, day 100 as an assessment for transplant. Then we will start to taper the immunosuppressants. I will talk in detail about it, the FK, cyclosporine, and sirolimus for sickle cell anemia patient if there is no GVHD. At 3 months, we will check the signs of chronic GVHD and the CBC and the test that we said in patients younger than 17 years, weight and height every 3 months, and signs of disease relapse. Engraftment. So what is the engraftment? For neutrophil, the engraftment is the first 3 consecutive days of achieving a neutrophil count more than 500, like 0.5. And platelet engraftment, more than 20 from platelet transfusion at least 7 days. Like if the patient received platelet transfusion, we'll count 7 days, then the engraftment more than 20, it will be counted. The 2 major factors that affecting the engraftment is the graft source, like in the cord blood, is associated with delayed engraftment, then bone marrow, then peripheral blood, which is the most fast engraftment. Conditioning regimen, non-myeloablative, then REC and myeloablative. Engraftment failure means never achieving the ANC or a platelet engraftment that's like ANC more than 0.5 or a platelet more than 20. Secondary or lost graft means ANC goes up to the 0.5, then it will drop until additional cells are given. Important to exclude the causes that lowers the ANC, like if there is a patient is taking any medications or he have any viral infection. Causes of graft failure, immunologic rejection by recipient T cells. Important that conditioning regimen has adequate lymphodepletion, viral infection like cytomegalovirus, human herpesvirus, parvovirus, drug toxicity, sepsis, and some patient diseases like myelofibrosis. Risk factors for graft failure, donor-recipient HLA mismatch, unrelated donor, alloimmunization like the donor pregnancy and transfusions, cell dose, minimum 2 million, and stem cell source cord blood, as I said, bone marrow, then peripheral, and the cord blood is associated with delayed engraftment, and reducing sensitivity transplant. Treatment for engraftment failure, after we look for the underlying cause, if it's not caused by any medication or viral infection, either to use the growth factors or stem cell boost, especially if autologous and stored cell available, and or at the end retransplantation. Chimerism test. The chimerism test, first of all, the chimerism derives from term chimera, which is a monster from Greek mythology that is a part of lion, goat, and serpent in one body. So the medical point of view is that the word chimera is used to define an individual in whom cell population from genetically different individuals coexist. Frequency of chimerism, the standard monitoring is day 30, day 90, 6 months, and 1 year, and annual if indicated. Specifically in myeloablative conditioning, it will be day 90 and 1 year. But in case of suspected graft failure or a disease relapse, it can be repeated. General measures to prevent infections. Patient before discharge from the inpatient, he must know that to avoid crowds, use mask when in public places, adhere to catheter care requirements, like central lines to be changed, the dressing to be changed Q7 days, no fast food, adhere to the well-cooked home meal, visit the doctor 1 to 3 times per week for the first month, use a caregiver for transportation, shopping, and cooking, avoid contact with children and pets, and he may be able to turn back to the work 6 months as per MRB, and if he's stable. What is the calcineurin inhibitors? First of all, it is a milestone of the stem cell transplant, especially allogenic transplant. It prevents the prevention of allogenic post-organ transplant rejection. It is more T-cell selective, and each visit, it will be monitored the level in the blood. Mechanism of action. To make it very clear, it's that the tacrolimus and cyclosporine, they are working the same pathway, but they are different in combining to the, like for tacrolimus, it will bind to FK12 protein and form a complex. that prevent or what's that, like to prevent the cyclosporine, what's that? I forgot its name. Yes, what is it? Okay, we'll just, yeah, later. It binds to FK506 protein 12. This is for tacrolimus, a different protein to that cyclosporine does, but the same pathway. They both prevent the generation of NFAT, which is stand for nuclear factor of activated T cell, that is responsible of production of interleukin-2. And the nuclear factor of initiating gene is a transcription for lymphokinase like interleukin-2 and interferon gamma, leading to suppression of cytokine production and thus inhibition of T cell activation. And the same for cyclosporine, it binds to cyclophilin and prevent the generation of a nuclear factor of activated T cell. Sirolimus is for patients with sickle cell anemia. It is a natural macrolide antibiotic that exerts its immunosuppressive effect by inhibiting cytokine-driven signaling pathways of the T and B cell via M-motor blockade, and specifically inhibiting the progression of cells from the G1 phase until S phase. The advantage that the sirolimus has a completely different toxicity profile to calcineurin inhibitors and can be used in combination with them. Drug levels, I'll just go through it very fast. It depends on the conditioning regimen and the type of donor. Like for myeloablative and malignant condition and with match-related donor, cyclosporine level will be ranging from 150 to 250. And to make sure that tacrolimus, for patient who is taking tacrolimus, it ranges from 5 to 15. When to start to taper, we'll taper 10 to 20% weekly starting from day 60. For a patient with myeloablative and match-related donor, cyclosporine will range from 150 to 300. And for tacrolimus, the same thing. And we'll start taper from day 180, if no GVHD. Myeloablative, mismatch-related or match-unrelated donor, excluding from the haploidentical, cyclosporine from 150 to 300, and for tacrolimus from 5 to 15. And we start taper weekly from day 180 if no GVHD, and in malignant condition can be start sooner, like day 60. For RIG condition, cyclosporine from 150 to 300, and tacrolimus from 5 to 15, and we start taper from 180 days post-transplant if no GVHD. For cord blood transplant, cyclosporine 150 to 350, and tacrolimus from 5 to 15, and start tapering it from day 100 in malignant conditions and day 180 in non-malignant. And for haploidentical, the cyclosporine will range from 200 to 300, and tacrolimus 5 to 15, and we'll start taper from day 90 for malignant conditions and day 180 in non-malignant conditions if there is no GVHD. Side effects, it will cause hypertension, neurotoxicity, metabolic abnormality, hepatotoxicity, life-threatening bacterial and malignancies. We will go to the infections, most common infection post-stem cell transplant. I will not talk in detail about it. There is 3 phases, like pre-engraftment from day 0 to day 30, and post-engraftment from day 30 to day 100, and late phase. And this is the most common bacterial and fungal and viruses that affect the patient during each phase. So what's the risk factor for infections? Conditioning regimen, like using ATG or Campath, stem cell source, because related to the engraftment, the long period of engraftment, graft manipulation, peri-stem cell infection, like history of getting infection, post-stem cell infection, like GVHD prophylaxis using immunosuppressants. The prevention, so patient post-transplant must be covered by 3 antibiotics, viral, antiviral, antifungal, and antibacterial. For antiviral, For example, acyclovir, 400 milligram BID, it will be used for allogenic patient up to 1 year, and some research, they said, for lifelong. And for autologous, up to 6 months. And continue for patient if he's using immunosuppressant medication. And we should take on consideration to check CMV, PCR, and EBV weekly for the patient. For fungal prophylaxis, for example, fluconazole, 5 milligram per kg per day, from day 0 until day 75, until he gets engrafted. In case of active GVHD, we'll use, and the patient came back to take the immunosuppressant after he stopped it, we'll use posaconazole 300 milligram every 12 hours for first day, then it will be daily. For PGP, for allogenic prophylaxis will be used up to 1 year, and for autologous up to 6 months. And like, for example, Bactrim or Ciptra, it will be the start conditioning regimen until day 2, then it will be reused after the engraftment, post-engraftment. Common complications to monitor post-stem cell transplant. I just put it in a schedule, like the most common oral mucositis, which is inflammation and breakdown of mucous membrane lining the GI tract, and sepsis and principle of care, a life-threatening condition caused by apparent and dysregulated host response to infection. Hemorrhagic cystitis, it is characterized by a painful micturition and hematuria due to hemorrhagic inflammation of the urinary bladder mucosa. Sinusoidal obstruction syndrome or veno-occlusive disease, it's a clinical syndrome of liver toxicity developing early post-transplant, commonly manifest with jaundice, ascites, and painful hepatomegaly. Idiopathic pneumonia syndrome, it's the signs and symptoms of a pneumonia like hypoxia, dyspnea, non-productive cough or fever with radiological evidence of multilobar infiltrate. And patient must have no evidence of infectious pathogen or cardiac dysfunction or fluid overload. Usually happens within 2 weeks to 3 months post stem cell transplant, and the median onset will be from 6 to 7 weeks. Another most common complication, graft versus host disease. We have acute and chronic GVHD. Acute GVHD, when it starts less than day 100, it is a reaction of donor immune cells against host tissue. And the 3 main tissues that acute GVHD affects are the skin, liver, and GI tract. For the chronic, post 100 day of transplant, is a syndrome of variable clinical features resembling autoimmune and other immunological disorder. Manifestation of a chronic GVHD may be restricted to a single organ or site or maybe widespread with profound impact on quality of life. Last slide will be vaccination. First of all, why we should revaccinate the patient post-stem cell transplant? Because the antibody titers to the vaccine preventable diseases like tetanus, polio, measles, it will be declined between 1 to 4 years after stem cell transplant. So the patient must be revaccinated. We'll start at 6 months post-transplant, but nowadays, because of the pandemic, we'll start from 4 months with COVID vaccine. So when the patient reaches to the 6th month, he might completed all the COVID vaccine course, and then we can start with the regular vaccination. Live virus vaccines like measles, mumps, and rubella should be avoided in stem cell transplant recipient up to 24 months, and patients with active graft versus host disease or using immunosuppressant. For hepatitis A, vaccine is indicated for patients at risk, such as patients traveling to endemic areas and who have negative antibody serology. And isolation, this is most important, isolation for 4 to 6 weeks is necessary if live oral polio vaccine or live intranasal influenza vaccine is administered to one of the family members during the first year after the transplant, or if the patient is taking immunosuppressant medication, he must be isolate himself from this patient. Last thing, this is like reference in our center. Actually, I didn't put the autologous. This is for allogenic transplant, like day 30 post-transplant. If the patient is underwent to a RIC condition, we'll take the chimerism, and then after every 3 months for patient who underwent a RIC RIC conditioning. And day 60, if the patient have central line we should remove it at this period if he didn't need it for like any electrolyte replacement. Or at day 90, we'll do the disease assessment, and at day 4 months post-transplant, we'll do the PFT test. 6 months, we'll start vaccination, and if the patient needs gynae assessment, ocular assessment like Sika syndrome as a sign of GVHD, IGVHD, and then 12 months, we'll start the annual workup. To sum up, patient O2 and mainly allotransplant is at risk of developing complications, and this is all what I explain. Thank you.
Thank you very much, Ms. Amani, for this great rehearsal and refreshment for the BMT. Well done.
Allow me to introduce our last speaker for this session, Mr. Bilal Ali Al-Bloui. He obtained his Bachelor of Science of Nursing Science from Hashemite University. Currently, he is a hematology bone marrow transplant coordinator at King Fahad Specialist Hospital, Dammam. He has also been into research focusing on hematology, BMT, and other perspectives in improving stem cell collection from peripheral line. He's also an educator in BMT courses and became an active member of various committees and councils in King Fahad Specialist Hospital, Dammam. Please welcome, Mr.
Thank you. So difficult to get a presentation when you have corona. Sorry, I'm just joking. I'm trying to walk up you. Okay, guys. Thank you. First of all, just I want to thank the SSBMT organizer to invite me as a speaker in this conference. And today I'm coming to talk about how to choose the donor, the best donor for the haploidentical transplantation. Actually, my topic, I take my topic from two main articles published by EBMT. The first one was in 2019, and it was by EBMT, a consensus of recommendation for donor selection in haploidentical transplantation. The second one, how do we choose the best donor T-cell repleted HLA haploidentical transplantation? So my topic information, I just try to squeeze the information from the two main literature reviews that done by EBMT. And just we will talk about the factor that maybe it will affect our outcome of the patient. And I will start, inshallah, by this picture. All of us know the haploidentical transplantation. The patient, when we do the HLA test, human leukocyte antigen, he has two antigen came from the father and mother, like this picture. If you have the green line and the orange line from the father and the red line, a blue line from the mother, when they have the kids, the sibling, have this, sorry. I don't know if it's working this. Okay, this is the kids, our patient number 3 in the middle. He take the haploidentical, the orange one from the father. This is the first haplo. The second haplo taken by from the mother, the red one. This is our patient. When we do the HLA test, our result it will be like this, but it's number ABDR, and it's number from the father and mother. Our patient, he takes the orange one from the mother and the red one from the, from the father, the orange one, and the mother, the red one. He's lucky that he has fully matched donor, the first one, the first sibling. But sometimes we don't have this opportunity for this patient. He didn't have any donor. At that time, we will jump for the next step. In our hospital standard, we will go for mud search. If he has fully matched donor, we will go for mud search. If he didn't have fully matched donor, like 9 out of 10 or 8 out of 10, it's depend. We'll go for haploidentical transplantation. Previously, just in 1970, the haploidentical transplantation, when they initiated the haploidentical transplantation, it was very difficult transplant and so complicated transplantation. But with the development of the medication, development of the protocol, now the haploidentical transplantation results became near result for the fully matched mud transplantation. That's why it's attractive approach now to go for haploidentical transplantation for the high-risk patient like leukemia patient who didn't has any fully matched donor. Many haplostem cell transplantation protocol was involved in this at that time to be more success haploidentical transplantation, like TBF protocol, cytibia busulfan fludarabine, and after that we'll give boost cyclophosphamide as a T cell repleted for to prevent the GVHD because it's haplotransplantation. This is example for the protocol, and we have Job Hopkins protocol, flu-site TBI based. In our hospital, we are usually use the TBF protocol, boost cyclophosphamide. Okay, now we're gonna go to the characteristic, how we can choose a donor. If we have a lot of donor, haploidentical donor, how we can choose this donor? Really, it will affect our outcome, to choose the transplant. It's an outcome of a transplant when we choose this donor, or it's by chance. If the patient has 3 haploidentical transplantation, okay, tell your family to come, anybody from them, to come to do a donation for you, because it doesn't matter. We'll answer this question after my lecture, inshallah. So I will talk about the characteristic. I will focus about 2 factors. The first factor, it's HLA related. The second factor, it's non-HLA related. For the HLA related, okay, for the HLA related, there is a study from anesthesia found that the degree of recipient HLA incompletely was associated with incident of severe acute GVHD. Regarding the specific HLA allele and antigen mismatch, the most recent data from the EBMT demonstrated that antigenetic but not allelic mismatch, the HLA DRB locus was independent risk factor for severe acute GVHD in post-transplant cyclophosphamide. Demonstrated that the HLA-B mismatch was also independent risk factor. The B value in this research was significant. Acute GVHD and TRM, it will be high if the patient has mismatch in the B allele for the HLA for the haploidentical transplantation. Another finding by Huang research, the Chinese research, when they showed the greater HLA disability did not appear towards the overall outcome after non-myeloablative haploidentical bone marrow transplantation with high dose post-transplant cyclophosphamide. So in unmutated also haploidentical transplantation, also Huang research found that the HLA, B, and DR combination mismatch was an independent risk factor for a grade 2 to grade 4 GVHD and with chronic myeloid leukemia. You know the chronic myeloid leukemia, it's not first choice to go for haploidentical transplantation. They have first line, second line, third line, so difficult to decide for the CML patient to go for haploidentical transplantation with a lot of incident for acute GVHD for them, and the mortality for them it will be high from the acute chronic GVHD. Okay, and there's another studies for unmanipulated haplotransplantation with ATG or with post-transplantation cyclophosphamide showed that HLA disability did not impact the outcome. However, the donor selection, some specific HLA locales profile remain to be explored. This research by Chinese also, they said that where is it the mismatch, it will not affect the outcome. Anyway, as I told you from the beginning, this is my published, it's literature review. They will take all the researches that talk about these things, and they will just do filtering, and they will give the opinion on each other. I will go to next variable. The first variable, it was the HLA, direct related HLA, and the next variable, it will be donor selection based on non-HLA variable. The first things I will talk about it, DSA, then I will talk about donor age, donor gender, ABA compatibility, and risk rule of NK cell, and NEMA-NEBA, family relation of type of donation, and donor and recipient serum CMV status. Let us start with DSA. The DSA is donor-specific antibody. The first of all, if we have patient, he didn't have any fully matched donor, the first things we will thinking about the DSA. The DSA test. For the haplostem cell transplantation, there is possibility to a presence of circulation HLA donor specific antibody against in the recipient against to the donor. So we'll take the sample from the patient and they will do test to know if the patient has any antibody against the donor that we will choose. So the lab they will tell us if there is from the possibility haploidentical donor if there is any antibody against them or not. So most likely not most likely, usually will proceed with the negative DSA. Why? I will tell you why. There is contribution between the DSA to be positive or negative. The DSA positive, it will drive to graft failure or graft rejection. The first study was in they showed that if the patient have DSA positivity, it's high risk to be graft failure or rejection. In haplostem cell setting also reported that 3 out of 4 patients, which means 75%, that test positive, if the patient has test positive of the DSA, the MFI, which mean fluorescence intensity, if it's more than 1,500, it's high risk for poor graft or graft rejection. Galdstone study found that DSA associated with increased risk of graft failure after transplantation. More recently, Change reported that DSA, the MFI result, if it's more than 10,000, equal or more than 10,000, were correlated to primary graft rejection. The p-value for this study was 0.001, which means significant impact. And that DSA, the MFI, if it was 2,000 or more than 2,000, were strongly associated with poor graft function in patients that receive unmodulated haplostem cell transplantation with ATG conditioning. So now if we have donors and this patient is unlucky, he didn't have fully matched donor, and he has 3 siblings with haploidentical transplantation, and after the screening, unfortunately, we have DSA positive. What we will do? Will proceed with transplant directly? Sure, no, because as the previous study shows that the patient is high risk, 75%, is high risk for graft rejection or poor graft failure. So what we will do? We will do desensitization for the patient, and we will apply plasma exchange, intravenous IVIG, and rituximab and bortezomib. Then we'll repeat the test. If he became less than 1,000 or negative, after that we can proceed with haploidentical transplantation. In summary, DSA must be incorporated into the algorithm for haploidentical transplantation, and with either the ATG or post-transplant cyclophosphamide modality. Therapy that target DSA might improve clinical outcome for patients that are DSA positive and have only one haploidentical donor. The next variable that I want to talk about it, the donor age. Wang research found that donors younger than 30 years were significantly associated with lower non-related mortality and better survival compared with older donor. A transplantation using stem cell from younger donor is strongly associated with lower incidence of both acute and chronic GVHD. Moreover, younger donors are more likely to be physically fit, better than, and he tolerates the procedure of the stem cell collection better than the older one. In summary, for this, the benefit to using the younger donor has been confirmed for both T-cell depleted and T-cell repleted haploidentical transplantation, and show less acute and chronic GVHD. The next variable that I want to talk about is the donor gender. The donor gender, female versus male, and had adverse effect on the incidence of grade 2 to grade 4 acute GVHD, both in unmanipulated haplostem cell transplantation, both cyclophosphamide and ATG based on conditioning regimen. In T-cell repleted haplostem cell transplantation with ATG-based conditioning regimen, in summary, the male donor is preferable than the female in manipulated haplostem cell transplantation with ATG conditioning based, and also with post-transplantation cyclophosphamide. For the summary in the gender, as we mentioned previously, the largest study that done by Peking University group showed that transplants from the male donor were associated with significantly less non-related mortality and better survival. I will talk about the ABO, but I will not go deeply for ABO because our nice doctor, Ahmed Al-Bahrani, he has lecture about ABO, I think in the next session. Just I will mention in our data that the ABO compatibility, it will reflect positively or negatively. The best choice for us to have ABO compatible donor rather than if the patient have minor or major incompatibility. There is a lot of study regarding if the patient has major incompatibility for poor graft failure, or if he has acute GVHD or chronic GVHD. So in the summary regarding ABO compatibility should be considered when selected the best donor in stem cell transplantation and T-cell repleted. The order of selection should be ABO compatible, thin, minor, thin, major incompatibility if we don't have ABO same status. I will jump to next variable, the CMV status, cytomegalovirus status. What's the status that's preferable? We have a lot of research talking about the CMV. One of this research and good research talking about the best choice for us to have same status of the CMV IgG reactivation. If the patient and donor have CMV reactivation for IgG, it will be less CMV reactivation post-transplantation. And the worst scenario, if the patient, what regarding why the negativity, it's best scenario for both the donor and the patient, because they shows there is unknown pathophysiology for that, but they think that like the ABV post-transplantation, if the patient have the IgG positive, he's high risk for reactivation or not. Now I will go to another variable, NEMA and NEBA. NEBA, when the donor have recipient share inherited of the parental HLA haplotype, they are said to be mismatched for non-inherited material HLA antigen. We call it NEMA. And when the donor and recipient share inherited of the maternal HLA haplotype, they are mismatch of non-inherited maternal HLA, which we call it NEBA. So which is the best scenario for us? NEMA mismatched donor are expected to be less immunogenic than a cell from the NEBA mismatched donor because they contact between immune system of the mother and the mother across the antibody during the pregnancy and also during the breastfeeding for the baby. They thought the antibody, it will cross from the mother to the baby. And that give the patient some antibody against the GVHD. One study, other research showed patients that receive transplant from NEMA mismatched donor had significantly lower incidence of acute GVHD. And also, the Peking University group also found immune recovery of naive TRAG was more rapid when patients receive allograft from NEMA mismatched donor. So the summary for the NEMA and NEBA, the NEMA mismatch should be incorporated into algorithm for selection donor and manipulated haplostem cell transplantation, especially with ATG. The order of donor eligibility, first NEMA mismatch and second NEBA mismatch. Just I will go throughout NK cell. The NK cell are important component for a human innate immunity recovery early post-transplantation and provide anti-tumor and antiviral effects. During the period of severe lymphopenia, NK cell alloreactivity can potentially provide better anti-tumor effect, as documented by lower relapse rate and better survival in patients with higher NK cell number of early post-transplant. A donor with alloreactive NK cell appear to be a preferred choice for patients to receive TCD haplo identical transplantation, while more study needed to clarify this issue and T-cell repleted haplo-identical transplantation, especially with post-cyclophosphamide based in GVHD prophylaxis, because they thought the cyclophosphamide, it will deplete the NK cell, so the patient will be risk for GVHD more and more, and his risk for viral and tumor reactivation again. So just in summary, I will jump for this slide, like algorithm for the patient who has haplo-identical transplantation. First of all, if there is no fully match, in our standard, we will go for MUD search. If he has fully matched donor from the MUD, we'll go for MUD. But if not, or 9 out of 10, we have one patient, like just for example, before 1 year, we search about donor for him. He has 9 out of 10 as MUD, but we went to haplo-identical transplantation from his mother, and he's now, after 1 year from the transplantation, he's doing fine. And now, recently, the data regarding the match-unrelated donor and haplo-identical transplantation, it's about to be similar than the outcome. So the first of all, we'll go for DSA test, as we mentioned before. If the DSA negative, we will jump to another variable, ABO, then another variable. If the patient he has DSA positivity, we have to manage the DSA first of all, before to go to transplantation or to proceed with transplantation. We'll do a plasma apheresis with rituximab, IVIG, and we'll do the test again. If the MIF less than 1,000 or negativity, the best scenario, we will go for after that. But before, we cannot go because high risk for graft failure or graft rejection. And this is another variable also, the CMV status, IgG, the best scenario, as we mentioned, negative for both, or IgG positive for both, and the patient, he will be high risk to CMV reactivation if the patient has negative and positive and the donor has negative, because there is no cross of the antibody from the donor to the patient, and the patient, he has previously CMV reactivation. So he's high risk to CMV reactivation, and the CMV reactivation, it will threat our transplantation sometime. Just summary, DSA, when we choose the best DSA, it will decrease the TRM. Young male donor decrease also the TRM, ABO, and full haplotype mismatch donor also decrease the TRM and decrease the relapse. NK allo reactivation, for the donor decrease also the relapse. NIBA mismatch decrease also the TRM of our transplantation. Thank you all.
Thank you, Dr. Bilal, for this interesting topic. We are ready for questions and answers, and then we will have a break.
Assalamu alaikum. Good morning,
Kindly,
everyone.
the speaker, they can come here, please. Amani, Miss.
Good morning, everyone. Ziad Al-Shaybani. Thanks for the panel for the great presentations. I have two questions to Amani and two to Michelle. We are seeing a lot of family breakout after transplant. So my question is regarding the mental health and behavior follow-up and sexual education to the patient and recipient, to the partner. Would there is any specific tool? Are we collaborating with gynecologists when we are sending our patient to search for ovarian function? And because sometimes the patient will not discuss with this, and even when we are discharging the patient or seeing them in the consult, we don't elaborate on this part due to culture sometimes. The second question is regarding the alcohol consumption after transplant. If there is New Year, Christmas, certain party, what you advise your patient regarding the alcohol consumption. To Amani is regarding after transplant, when the patient is leaving the floor, will in your center consider like VIP line if this patient coming to the clinic twice a week for big line, blood work, usually they need electrolyte replacement. Instead of waiting, are you waiting in the regular clinic or they are going, for example, to transfusion unit and someone will see them there? And the second one is regarding the patient who's coming from outside Riyadh or living far away from the emergency department in your center. What's your advice for this patient? Thank you.
Is this what? Great, thank you. Thank you very much for those questions. Yeah, absolutely important aspects of care for our patients. So from a sexual health, sexual functioning perspective, we begin the counselling for patients, maybe with their partners, right from the transplant preparation phase, and we continue that input and those conversations during the post-transplant phase. You're absolutely correct. A lot of our patients don't really want to discuss that, and during the early weeks and months after the transplant, for them it isn't a priority. So they want to park that and make sure that they're in remission, they're able to take their meds, and all of the other aspects of their post-transplant care are running smoothly. So what often happens is that we pick that conversation back up when we see them in the long-term follow-up clinic through the holistic assessment and also the direct questioning that we do as part of our follow-up schedule. So it's incorporated, it's a question that's mandated through our follow-up. Of course, we don't mandate that the patient responds and has that conversation, but they have the opportunity. Every single time that they come to the clinic, they're able to talk about it. And I have found that some patients will not want to talk about it during years 1 and 2, and then as years 3, 4, etc. come along, it becomes more of a priority as they start to resume their post-transplant person and find their way socially as an individual post-transplant. So yes, we have gynecology, yes, we have erectile dysfunction, all waiting for when our patient is ready to have that conversation and start embarking on that. As part of our counselling, we also use the evidence around being sexually active within the first year after transplant, sort of favours well for sexual function much later on after transplant. And of course, that works very well if people are already in an established relationship or are of kind of sexual functioning age. But for those that are not in an established relationship, of course, that's more difficult. And so we provide that support. So we refer to gynecology from 6 months after transplant, and particularly for our female patients that have graft-versus-host disease, because we know that the graft-versus-host disease is very much hidden for those patients, so that they then don't have issues later on. And we continue that process with the gynecologists ongoing. We're very fortunate that they're part of our extended team. And for our patients so for our patients that are struggling mentally, again, we pick that up. We actually offer in our post-transplant clinic a psychosocial screening to our patients. Again, it's optional. It's offered to them once a month or less often if they're coming less frequently to the clinic. And again, it's an online. The report from that psychosocial screen, so it includes PHQ-9 GAD-7 established scoring systems for mental health, plus some other additional questions. And then we can address that within the context of the clinic consultation. So there are many opportunities for our patients to report their mental health and well-being. We also have, we're very fortunate, we have 3 psychologists within our department dedicated to the care of our hemato-oncology patients. with also the transplant patients included within that, and we also have a social worker. So we're blessed with the resources that we have in-house that we can refer the patients to. From the alcohol perspective, so we use the national guidance in the UK for alcohol consumption, so maximum 14 units per week, and it's not a target. It's just a guidance, and for people not to consume all of their alcohol units regularly in 1 or 2 days, and to make sure that they have regular alcohol-free days throughout the course of a week. And, this becomes important when we have patients who regularly will drink half a bottle of wine in the evening. That will be every evening. The alcohol units soon build up. Actually, a lot of people don't fully understand what makes up 1 unit, so we provide education around that. We have a nice leaflet that isn't overly preaching to patients, but it provides a guidance around what happens when you consume a lot of alcohol very regularly or too much and exceeding those guidance. So we use props and information that helps to kind of support the conversation that we have with the patients. Of course, when patients are very early after transplant, the guidance around alcohol consumption is very different because, of course, the liver is working really hard at that point, and we don't want them to have additional toxicity or interactions with other drugs that they might be on. So, the guidance is different at that stage, but again, as patients become on less medication and start to resume some of their social activities, then often there will be a natural increase in alcohol consumption. And some patients live in fear of drinking alcohol as well. So, they avoid drinking alcohol even though it's something that they want to do. And again, we'll offer some positive reassurance around that if it's an important part of their life. So yeah, we offer a lot of information around that. Thank you for your questions.
For the first question, before discharging the patient from the ward, we give them the card that it has the emergency numbers and the extension of our stem cell coordinators. And regarding the visit, they can reach us anytime during working hours. But regarding the working hours, we have a assigned line. It's emergency line. It is a phone number. It's a WhatsApp, and they can call us. And the stem cell coordinators, they are responsible for receiving these calls. And we can organize with the patient what time they can reach us. And in case like the patient have emergency situation during weekends, we have assigned ER bed in the ward. And the patient less than 100 days, he can reach via the stem cell coordinator that holding this phone that time. She will organize it with the physician and the on-call physician, and he can be seen in the ER bed. Yes?
Like hotline.
Yes, like hotline. And by the 100 days, still he can reach the clinic, and he can use this phone. And if the patient was outside Riyadh, we had so many experience. One of the patient that when we are tapering the tacrolimus, he stopped it by himself and he traveled, although that we instructed him to stay in Riyadh, and he developed GVHD. He was in Al Medina, but he called us via the phone. He was admitted to the ER in Al Medina hospital, and we organized with the physician there, and we bring him to our hospital. So everything is settled. For the second question, sorry.
Regarding the workup in the morning when he came for routine visit, will he be waiting in the regular waiting area?
We'll accept him as walk-in, and we have another, it's like a daycare unit that even we accept the walk-in patient there.
So Dr. Bassem, what do you advise your patient if they are living in the floor and they're asking about holy water, zamzam, honey, olive oil, can we use it during the chemotherapy? From Islamic perspective, this means a lot. Dates.
So for these things, in my opinion, no problem. My colleagues, they will say no. But I ask them, where's the evidence? They said, no evidence. I said, then I use it. It should be sterile. The honey should be sterile. It's part of the culture. If you go to every country in the world, they have their culture background. In Canada, we have the Chinese. the Greek, the Italian, and they did study at Princess Margaret Hospital. They found 50% of patients that are using complementary or alternative at the same time of transplant or chemo. So we should allow it, and with the knowledge of the physicians, so we know what's going on. I have big faith in these things that it will help at least augment the spirit of the patient, if not having a real physical or scientific evidence. But if the patient knows that there is a hadith or ayah about these things and he or she using it, it will really empower his spirit and morale. So that's my piece. If you allow me, Mr.
Please.
I think
Please.
I liked the presentation of all the nurses, but there is one thing I will come to you. In Saudi Arabia, we will talk about Saudi Arabia. So what's lacking in Saudi Arabia for nurses is the nurse practitioner. I think we see that you have all the capabilities. I know in UK, in Canada, they have it, and they are really very powerful. What I noticed here, it's in the process with the Saudi Commission to get the license, but some institutions, they started to give the full trust. The nurse practitioner can write the prescription, they can do bone marrow, they can do all procedures. Why we are crippling them with these regulations? So I think it's time to say أعطيني حريتي أطلق يدي إنني أعطيت ما استبقيت شيء. Meaning in English, free my hand.
Yeah.
I gave everything, so give me the freedom and free my hand. That's the title.
Yeah,
Thank you.
thank you. From our experience at King Fahd Specialist Hospital, Dammam, just recently, a few months ago, one of our clinical nurse practitioner even, she graduated from USA. She worked with us for almost 10 years. But really, to be honest, as you said, we did not have the freedom. The Saudi Commission did not give us the approval to work. By the end, she's expert in oncology. She ended by family medicine for 3 years, just seeing regular diseases and supporting the family. It's a great job, but her passion and work is in medical oncology, actually it was. Inshallah, in the future, yeah. Thank you.
One question there.
Yeah, there is one question, yes.
My question is Dr. Basim. Thank you very much for your innovation lecture regarding CAR T-cell. It is unfortunate that we don't have this CAR T-cell program in our institution. But however, this is our future dream. So whenever if we want to constitute this program, what are the areas that will, the multidisciplinary teams that we should involve in this journey of success?
So, in the Western, they have the collaboration between research center and the clinical hospital. So it's from bench to bedside, bedside to bench. Here, the universities, they have outstanding research center. They have the teaching hospital, but it's not. The transplant center, they don't have the background of research center, except very few, maybe one or two. But I think we really need more collaboration between the scientist and the clinician to have the collaborative work. And if we do so, we will be able to be successful.
Thank you very much. Thank you. The break time, we are late now. How many minutes will we break? 15 minutes. We'll go for 15-minute break. Thank you very much. It was a great session, full of interaction and inspiring and refresh information. Appreciate it. Thank you, everyone. Thank you.
Thank you.
Okay, welcome to the second part of our meeting. I'm Olivia Salazar, and I'm with Ashwak Alutaibi, the Clinical Nurse Coordinator, Adult Stem Cell Transplant in King Abdulaziz Medical City in Riyadh. Our first speaker will be talking about ABO incompatible and hematopoietic stem cell transplant. Dr. Ahmed Barani is a graduate with MBBS from King Faisal University, Riyadh, and carried on with his fellowship in hematology from King Saud University, Riyadh, Saudi Arabia. He finished his clinical fellowship in transfusion medicine, stem cell transplant in McMaster University, Hamilton, Ontario, Canada. Currently, he is a consultant, hematology, transfusion medicine, and stem cell processing, as well as the head of both stem cell transplantation laboratory and of therapeutic apheresis unit in King Fahad Specialist Hospital, Dammam. In addition, Dr. Bahrani has been active in a number of research and peer-reviewed journals. Good morning, Dr. Bahrani. You may begin your talk. I'm sorry, doctor, we cannot hear you from here.
Can you hear me now?
Yes, yes, you may begin, doctor.
Can you see the slides?
Yes, we can. You may begin.
Okay, thank you very much. Thank you for the nice introduction. Thank you for the SSBMT. And thank you for the organizing committee. Okay, I will talk with you. It's an honor to speak for you today about the ABO incompatible hematopoietic stem cell transplant. This is a very important topic in the field of stem cell transplantations. This is our hospital, King Fahad Specialist Hospital in Dammam. We are doing almost 100 stem cell collection per year. It is both pediatric and adult. Benign and malignant hematological diseases also are involved in this program. There are so many indications for the hematopoietic stem cell transplantation. Many of the indications are hematological malignancy, myeloma, lymphomas, acute leukemias, neuroblastomas, and chronic leukemia as well, and myeloproliferative disorder. Also, there is a long list of benign hematological diseases. Also, we can do for them hematopoietic stem cell transplant. We have aplastic anemia, thalassemia major, Fanconi anemia, pure red cell aplasia, sickle cell disease as well. And the list is long, and many of the indications are either autologous stem cell transplant or allogenic. But of course, for the diseases that involve the bone marrow, of course, the choice is allogenic stem cell transplant. The autologous and the allogenic, the autologous is straightforward. We are taking the stem cell from the patient or from the donor, which is the patient, and we resecure the bone marrow. Then, and after the chemotherapy and conditioning, we re-infuse back the stem cell to regenerate the patient on bone marrow. But in case of the allogenic, we have we need a donors, which is most of the time he is a sibling of the patients, and there is match related and match unrelated donors. Also, we have the ABO compatibles versus the ABO incompatibles, and we have the haploidentical stem cell transplant. Also, the conditioning chemo is either myeloablative or non-myeloablatives. What are the sources of the hematopoietic stem cell transplant? This is very important in terms of ABO incompatible stem cell transplant. Of course, we have the bone marrow harvest, and this is represent almost 20% of all cases of allogenic stem cell transplant. But the issue with the bone marrow, that the RBC content is 23 to 25 to 35% of the bone marrow. The widely used source of hematopoietic stem cell transplant is the apheresis technology, peripheral blood stem cell collections, and the RBC content in this type or this technique of stem cell collection is very minimal. And the hematocrit usually of the product, of the good collected product, is 2 to 3%. And the cord blood is another source of stem cells. The volume is very small, and it's almost 25 ml. And it is good for pediatric patients. This is the roadmap for the allogenic stem cell transplant and the allo donors. As you can see here, we start with GCSF for about 5 days. Then the stem cell collection will be on the 5th day or the 6th day of the GCSF administrations. Whenever the target of the peripheral blood CD34 count is enough to have successful collection. This is from the registry, the World Registry of Transplant by the Cell Source. The yellow colors represent the bone marrow, whereas the green color represent the peripheral blood stem cells, and the orange color represent the cord blood. As you can see here, the majority of the transplant and the majority of the source of the stem cell is by peripheral blood stem cell collection. And the bone marrow and the cord blood almost have less percentage with equal number almost. The ABO blood group antigens, we have a fact that the ABO blood group antigens are not major histocompatibility antigens. And the ABO blood group antigens are not expressed on the stem cell. This is why the mismatch of the ABO blood group between the donor and the recipient is not a barrier for a successful HBC transplant. Of course, the priority is to have sibling with ABO match, but if there is no donor with ABO match and HLA match, then our second option will be ABO incompatible HLA match sibling donor. This is from the international figure. Of course, our figure in Saudi Arabia is different. We need maybe collaborative research or data collection in our country to see what are the percentage of HBC transplant by ABO incompatibility. From the worldwide figures, the HBC transplant with ABO incompatibility represent 40 to 50%. And the major ABO incompatible transplant is about 20%, and the minor are also another 20%, and the bidirectional 5%. And I will explain in the coming slide what is the difference between the major, minor, and bidirectional as well. This is a study, multiple studies. The conclusion of this multiple study that there is no difference in the outcome, also in the survival, also in the graft versus host disease risk between the ABO compatible and ABO incompatible stem cell transplant. The major ABO incompatible hematopoietic stem cell transplant, it is characterized by the presence of anti-donor blood group antibodies in the recipient plasma. The antibody is either anti-A or anti-B antibodies in the recipient plasma against the A or B antigens that is available on the RBC on the donor stem cell product. This table will show you the different scenario of the major ABO incompatible hematopoietic stem cell transplant. The recipient could be O blood group, and the donor is either A, B, or AB. The other scenario that the recipient could be either A or B blood group, and the donor is AB blood group. So if the recipient blood group is O, there is anti-A and anti-B in his plasma. This anti-A and anti-B will be incompatible with the A and B antigens in the donor RBC. The plasma anti-B antibody, and this anti-B antibody is incompatible with the B antigen or A antigens on the donor RBCs. What are the adverse reaction because of the major ABO incompatible hematopoietic stem cell transplant? There will be maybe acute hemolysis, delay in the RBC engraftment, and pure red cell aplasia. What are the interventions? The intervention should be done by red cell depletion. Of course, if the source of the stem cell product is apheresis and the hematocrit is only 20%, so with every 100 ml of the stem cell product, there will be only 2 ml of RBC, which is not an issue. But if the RBC content is more than 20 ml, and or if the recipient agglutinin is more than 32, then it is an issue. Of course, with all apheresis product, there is no issue because most of the center, they collect apheresis, peripheral blood stem cell collection with hematocrit between 2 and maximum 4%, unless there is a problem with the collection by itself. But in the bone marrow collection and the bone marrow harvest, in which the RBC content exceed 20%, then we need to do red cell depletion. Red cell depletion should be done for both, for the fresh and the cryopreserved product. And also we can split the units. If the volume of the apheresis product is large, the volume, we can split the unit and can be infused over 2 days, or we can give an interval of 8 hours between each infusion. Another intervention, we should also select and transfuse ABO appropriate product. The recipient isoagglutinin removal before transplant by TBE or immunoadsorption, but this is not a widely used technique. The minor ABO incompatible hematopoietic stem cell transplant, it is characterized by the passive transfer of incompatible blood group antibody from the donor to the recipient. The recipient RBC incompatible with the donor isoagglutinin, and usually the recipient is either A or B, and the donor is O, so there is anti-A or anti-B antibody in the donor product against the recipient RBC antigen. Or could be the recipient AB blood group and the donor O, A, or B. What are the adverse reaction with the minor ABO incompatible hematopoietic stem cell transplant? Acute hemolysis can happen, but usually it is mild and self-limited. Delay hemolysis, this is caused by the passenger lymphocyte syndrome. The intervention that we are doing for this type of ABO incompatibility is to do plasma reduction and also to transfuse ABO suitable product with a close clinical and laboratory observation between day 5 and day 15 after the HBC transplant to detect the hemolysis. The bidirectional is a combination of both major and minor group A donor again and B recipient, or group B donor and A A recipient. It's either from A to B or to B to A. The intervention is combination of both used for major and minor. So we should do both volume reduction and red cell depletion. And again, as I mentioned with the red cell depletion, it is not indicated in the apheresis product because the RBC content is very minimal. It is indicated mainly with the bone marrow harvest. The adverse reaction with the bidirectional is both major and minor. This is a table with a summary of what I already mentioned before. As per AABB, which is the American Association of Blood Bank, and fact, all donor and recipient must be tested for the ABO, for the RH blood group, and also antibody screening to detect if there is any antibody against the minor RBC antigens. And every institution should establish their own guidelines and their own cutoff figure for the RBC content of the product. Indications also for processing of the HBC. Every center should have an indication for the processing, and also description of the processing method. The product infusion criteria, the intervals, is it daily, the maximum volume to be infused to the patient within 24 hours. And each institute develop their own guidelines for the transfusion support. This diagram will actually summarize also the intervention that should be taken in case there is ABO incompatible transplant for the major and for the minor. So if the titer is more than 32 and the RBC content is more than 20, then red cell depletion should be done. But if the titer is more than 32, but the RBC content of the product is less than 20 ml RBC, no intervention should be taken. For the minor ABO incompatibility, if the titer and the recipient, the donor anti-recipient titer is more than 1 in 256, then a plasma depletion of the product is indicated. Red cell depletion and the plasma reduction, there are so many techniques to do the red cell depletion. It can be either manual or automated. There are several machines available in the market for the automated red cell depletion and volume reductions. Usually there is Fickel hypopic density gradient separation with centrifugation. For the RBC depletion can be done manually. Manual RBC sedimentation depletion using starch, or can be automated centrifugation with Buffy coat cells. Plasma reduction is much simpler, of course, than the RBC depletion. It is a simple centrifugation followed by plasma expressions. With all these manipulation, there will be some loss of the stem cell during the processing technique. But we are expecting that recovery should be more than recovery of the stem cell, and the product should be more than almost 70% of the total stem cell. The adverse reaction with the ABO incompatible hematopoietic stem cell transplant, the acute hemolysis, is sometimes happening, especially if the red cell at the time of stem cell product infusion, the quantity of the RBC and the volume is high, or there is a high titer of the recipient isoagglutinin antibodies. Usually we have to monitor for the acute RBC hemolysis, the direct comb test, the LDH, haptoglobin, reticulocyte count, isohemagglutinin titers assessment, liver function enzymes, bilirubin, and peripheral blood smears should be requested. Also another adverse effect of the ABO incompatible transplant is the delay RBC engraftment. Usually the time of the engraftment will be delay of the RBC it reached from 23 to 73 days with the myeloablation, and with the non-myeloablation, it can be up to 178 days. Pure red cell aplasia, another adverse event. It is a maturation, arrest, occur in the formation of the erythrocyte. The incidence is between 6 and 30%. Usually there will be severe anemia. Reticulocyte count is less than 1%, with the presence of less than 0.5% mature erythroblast in the bone marrow. But the white cell count and the platelet production is normal. Basender lymphocyte syndromes, this is another adverse reactions. It causes delay hemolysis.
2 minutes, doctor.
Yes?
You have 2 minutes, doctor.
Yes? Okay, thank you. It causes delay hemolysis 5 to 15 days post-transplant. The incidence is 10 to 15% of recipient with minor ABO mismatch transplant. Usually there will be mild hemolysis. Of course, the transfusion support, we should give a leukocyte, reduced product, irradiated product, and the indication for the irradiation is up to 1 year after the infusion of the stem cell. There are 3 phases for the transfusion support. We have a pre-transplant phase 1, we have a peri-transplantation phase 2, and also post fully engraftment phase 3. In phase 1, the type of a product that we are infusing to the patient should be the same as the recipient blood group. In phase 2, this is start after the infusion of the stem cell, and usually the transfused RBC must be compatible with both the recipient and the donor plasma, and the transfused plasma and the platelet must not contain the ABO antibody against either the recipient or the donor RBC. In phase 3, after full engraftment is established, and after the reticulocyte count is more than 1%, and the DCT is negative, and disappearance of the recipient isoagglutinin, in this phase, usually the blood product that is infused should be same as the donor blood. This is after complete shift of the blood group from the recipient to the donor blood group. The suggested approach to ABO incompatible HPC transplant during phase 1, we should, of course, we should evaluate for the ABO, the RH, the antibody screenings. The antibody titer should be assessed, depend if it is major or minor. It is requested either on the donor or on the recipient, depend on the type of the ABO and compatibility. Finally, this is just a case study. It's just a brainstorming. This is this is a real case, 22 years old patient with acute myeloid leukemia. The patient blood group is B positive. The HLA match related donor.
I'm sorry, Dr. Barani, we're giving you another 2 minutes.
Okay, thank you. The mismatch related donor, HLA match related donor is his sister, and the blood group is A positive. So what is the type of the transplant? Is it major, minor, or bidirectional? This is, of course, as you can see, A to B. This is bidirectional ABO incompatible transplant. So what is the stem cell product processing technique? We should do both RBC depletion and the plasma depletion. And what is the transfusion support in the pre-transplant, peri-transplant, and post-engraftment stage? In the pre-transplant, we should give the patient blood group, B blood group. In the peri-transplant, we are giving the O blood group, which is compatible with both the recipient and the donor. And after the complete engraftment of the donor stem cell in the recipient, then in this stage, we will give the A blood group RBCs. This will show the mixed field reaction in case of ABO incompatible transplant, and this is, you can see there will be a shift in the blood group from the recipient to the donor, And during the peri-transplant phase, we will have both population, the donor population of cells and also the recipient population of cells. This is my last slide, the summary. ABO compatibility is not required for successful allogeneic engraftment. ABO incompatibility does not affect the neutrophil or platelet engraftment, graft failures, or graft rejection. Adverse reaction can occur, such as acute and chronic hemolysis following the ABO incompatible stem cell transplant. HBC product processing, either RBC depletion or plasma depletion, is indicated in some cases, especially with the bone marrow, and each facility should have a policy regarding HBC processing or a transfusion support for the ABO incompatible transplant. Pre-storage leukocyte reduction is important. Irradiation of the product is also important. And special consideration for the blood component selection must be taken with ABO incompatible stem cell transplant at the different stage of the transplant. Thank you very much.
Thank you for your meaningful presentation, Dr. Bahrani. We will move on to the next speaker. You may reserve all your questions after all the speakers' presentation.
Thank you very much.
So our next speaker is Mr. Osama Zamil. He has Bachelor of Science in Nursing and carried with Master degree in Nursing Oncology, both from Hashemite University, Jordan. He's the acting director of nursing in King Khalid University Hospital in Riyadh, as well as the nursing service manager, Oncology Center, King Saud University, Medical City. Further, he obtained a number of nursing-related certificates focusing on leadership. So without any further delay, welcome Mr. Osama. The microphone is yours. Thank you.
Appreciating your kind introduction as well, I would like to extend my gratitude to SSBMT, the organizing committee, for giving us the opportunity of sharing our experience concerning building the capacity for bone marrow transplant program in King Saud University Medical City, King Khalid University Hospital. So I would like to start with building the conceptual framework for bone marrow transplant program. We adopted a project management institute model wherein our core variable not only return of investment, rather than aligning the community needs for such specialized program. And I do believe the best starting point for this, we need to be proud of the national efforts which was exerted to structure such services. And I do believe Dr. Hani Al-Hashmi, Dr. Ahmed Al-Saghir, and many other leaders in the field of bone marrow transplant has published a core articles in 2020 under the title of Establishing Hematopoietic Stem Cell Transplant Program, Overcoming the Cost Challenge. Because it's known that such programs are specialized program and high-cost program, wherein majority of oncology centers are having the core services. However, they might be reluctant to establish such service simply because they are not having the collaborative techniques and services which might hinder them from structuring those services, considering the high demand of those services at the national level. So we have drawn the idea very clear. We were persistent and patient for our goal in order to achieve our outcome. So the roadmap for today's session, I will start with the program background, SWOT analysis, how we build the capacity with reflection on the implementation processes, what our current outcome, what the nurses' challenges that we encountered during the process of implementation, and finally, what's our future direction. as teaching medical institute, the vision of the organization to be one of the foremost academic medical city in the Middle East, which aims to advance the practice of medicine by nurturing future generation of health leaders. If we are going to translate this vision statement to our performance outcomes in the balance scorecard, you will be finding that our priority is learning and creating a future generation. So now it became a necessity for us to establish such service in order to provide comprehensive oncology center at the level of our area, which will give the opportunity for our future leader as a learner in our organization. Being a learning organization didn't attach us from other performance measures, including patient-related variables, customer-related variables. It's a fact that the demand for the oncology service is high, even though that we are having a lot of tertiary hospital at the level of Riyadh and other major cities, but still the demand is increasing. And one of the core elements that was reflected by Dr. Al-Hashmi and other leaders in their paper, they said that we need to go through 4 phases in establishing and consolidating the bone marrow transplant program across the kingdom. Phase 1 is assessment, whether those oncology centers are having the core services. And the most crucial phase is what? Is the planning. Phase 3, activating the center, and the most challenging one is sustainability of those services. Due to the current situation and the data which was presented from 2012 up to 2016 at the level of the national level, one of the main challenges is the patient accessibility to the specialized services, mainly the bone marrow transplant, as well the oncology service. So the oncology center in King Khalid University Hospital being established in 2016. Prior to that date, we were integrated under the medical services. The core services were there, however, it's not well defined. Radiotherapy, chemotherapy, surgery were there. However, the advanced services like nuclear medicine, advanced lab testing wasn't well defined at the level of the organization. And this was the trigger zone for us that in order to enhance our patient experience, patient outcome, achieving the vision of the organization, we need to redefine the scope of service of the oncology center to be aligned with WHO model, which caring of the patient and community from the phase of prevention, screening program, up to palliative and hospice care. So the mission were structured by December 2017 to establish well-structured program. And when I said well-structured program, meaning it contains all required services of autologous bone marrow transplant. And we intentionally started with autologous because the requirement for structuring autologous program is less than the allogenic, wherein we do believe when we have done our feasibility study that we need at least 2 to 4 years to structure the allogenic bone marrow transplant program. We cannot deny that COVID pandemic affected significantly our plan for many reasons: availability of resources, accessibility to another organization whom they are considered as our partner in the process, but still, always we were focusing toward our goal. We need to make the center as comprehensive center. At the same time, still, the IOM report, which was released in 1992, was at the back of our mind, which is crossing the quality chasm, providing safe care in timely manner. which, to be honest, one of the key variables that always we will look into when we structure this program. So the key findings of our SWOT analysis, as you can see here, we are talking about educational medical institutes. We are having highly qualified medical team. We are having the physical setting. Availability of a drug, frankly speaking, it was a strength and weaknesses at the same time. We encounter a challenge of availability of certain mobilizing agents at the level of the organization. Resources and funds are there. The core weaknesses that we encounter at that time is the availability of advanced services, including CD34 enumeration. We used to do validation for our reading with other 2 test centers, as well the integration of other support services like angio, like blood bank and apheresis unit. Opportunities, we have many other organizations whom they are willing to support our program. We cannot deny that King Fahd Specialty Hospital in Dammam, National Guard Hospital in Riyadh, they supported us a lot till the moment during the successive implementation of this program. And finally, the threats that we encounter is again the cost and the sustainability of the required resources and meeting the regulatory requirements. Going back to the core skeleton of the program, following the Durobedian model. Structural-wise, we identified that we need to work on the team competency, nursing, clinicians, structuring the policy and the procedures, and adopting the standards of care, and integration of all support services. At the level of the processes, is assigning a clinical coordinators in order to facilitate the process of caring and defining the treatment roadmaps. And at the level of the outcome, how we are going to structure a proper follow-up program, taking notes that we are having late side effects or adverse effect of bone marrow transplant program and maintaining sustainability plan. So again, this is the main challenge that we encounter. How to make homogeneous structure in order to make sure that we are building successful bone marrow transplant program. So here, and I will go to Dr. Bassem's statement, when we said concerning nursing practice. Yes, you are right, but I would like to reassure you that we are having the right steps. Princess Noura University, the digital university in Riyadh City now, are graduating nurses with master degree as advanced nurse practitioner. And we are having now initial communication with them to define their scope in aligned with their educational competency. As temporary plan, we had a partnership with Oncology Nursing Society to build the competency of our nursing team. As well, we sent our nurses for well-established institute like National Guard, King Fahd Specialty Hospital for fellowship in order to monitor and to learn the culture from their organization. The transplant ward, we work physically to prepare it with HEPA filter as well positive and negative pressure room. Blood bank team were not detached from the plan. They've been sent to another organization whom they are having well-defined program to mentor the process, how it's done there. As well, the ad hoc team and the pharmacy team. The pharmacy team being provided with all roadmaps in order to make sure that all required drugs and chemotherapeutic agents will be available at the time of a transplant. Even we did not omit the scientific reference for the whole team. We have subscription for all our oncology team and task force team for the digital library in order to maintain the accessibility for the required information. And on top of that, we made sure that we are integrated successfully the support team, which they are playing significant role in determining the outcome of the bone marrow transplant program, including social services, nutrition department, and socio-oncology. And here is the implementation plan. In 2017, we started with autologous multiple bone marrow transplant program for multiple myeloma. 2018-19, we expedite the autologous to include the lymphoma patients. And in at that time, from 2020 till 2021, COVID impacted the progress of this program. At the end of 2021 and 2022, we proceeded with allogenic transplant program. And this is summary of the journey till we were able to structure the autologous bone marrow transplant program at the level of multiple myeloma. And here I'm sharing the key outcome of the program from the moment of structuring this initiative. In 2017, we had 10 cases of autologous bone marrow transplant program, and mainly it's for multiple myeloma. In 2018, we were successfully capable to do 12 cases, 2 for lymphoma and 10 for multiple myeloma. In 2019, we have done 10 cases, and in 2021 till 2022, we have done 4 cases of allogenic and 6 cases for autologous. So, per disease, we have done 20 cases as multiple myeloma, for lymphoma 6 cases, and for allogenic 4 cases. And I'm coming toward the end of my presentation. Remember that the nursing team are the core team behind the successful implementation of those programs, because they are the one whom they are the frontliner with the staff. They are the one who's doing the facilitation and the coordination of the services. We have encountered many challenges during our journey for implementation. And here I'm talking about the nursing team. And starting by core and evolving knowledge, wherein we overcome it by adopting the international competency framework by Oncology Nursing Society. We trained our educator and resource nurses to structure and inculturate those competency among our frontline nurses. We gave them the opportunity of being cross-trained in another organization whom successfully they implemented this program in order to make them ready and valuable to handle such high-risk population. Even though at the level of the hands-off, we have sent them for specialized training courses outside the country in order to sharpen their competency handling advanced procedure. At the practical level, the roadmaps the staff being given the opportunity for deep exploration of disease-specific roadmap. And if you notice at the very beginning, we are having naive steps before we are expediting those programs. And simply the reason behind that, we want to make sure that we are inculturating and building those programs in a fixed and well-structured basis. Patient education, considering the nurses' demographics at the level of our organization and the need of bilingual nurses. Structuring and building the roadmap and the assessment sheet on the electronic system. Structuring a proper follow-up program post-transplant when the patient are going to be discharged. Nursing familiarity and competency how to handle patient with GVHD. Moreover, which I do believe majority of the organization currently are encountering, which is the high turnover of the nurses team. Meaning, and this alerting us that still we need to build the competency for the new arrival at the level of the organization. as well the last challenge, which is the availability of the supplies and the resources. So where we are heading, inculturating autologous allogeneic bone marrow transplant program, expediting the scope of practice for the oncology center, as well successful integration of independent allogenic bone marrow transplant program. Thank you very much.
Thank you, Mr. Osama, for the next presentation. Our third speaker.
Our third speaker prepared
In 2016, there were malignant cases of 1,500 cases, and it jumped to 1,700 plus, meaning there is an increment on the number of cancer cases being accepted in King Fahad Specialist Hospital, Dammam. And this data is further supported by the increasing ambulatory visits. So from 2016, there was 45,000 plus, and it jumped on to 49,000 plus with a 7% increment. These are the services that fall under Oncology Center. Just to show you the statistics between the year 2016 and 2017, it's medical oncology who slipped down a bit with 8%, but the clinic that caters for the patients on active chemotherapy treatment have shot up to 6%. The most noticeable increment on this slide is the adult hematology services with a whopping 24%, together with the ambulatory visits in the BMT clinic with 13%. Hence, the Director of Oncology Center at that period, 2017, have thought about forming the outreach program. And the last data, but not the least, is the pediatric ambulatory visit with an increase of 7% on that period. Also shown here is the pediatric and adult top diagnosis with their appropriate percentage. Knowing all of this data that has been gathered between that time frame, the Oncology Center have decided to embark on this outreach program. But before going to an outreach program, let's see what are the steps to go on that pathway. So what is an oncology center program? This is a systematic approach to deliver an oncology healthcare services beyond the hospital to a certain population in the community wherein the population might not have access to these services. And oncology outreach clinic is defined that a clinic set up in another healthcare facility wherein it was initially staffed by the physicians, nurses, pharmacists, and other allied healthcare from KFSHT. This is the roadmap for the establishment of the Oncology Outreach Program. It has 3 stages, and the first stage is the planning. Planning is further divided into 4. Second one is the development of action plan, and lastly is the implementation. The first step in planning stage is to assess and to identify the best location for the outreach service. The hospital managed to establish 3 outreach services, but for the sake of this presentation, I will focus on to the Alhasa outreach program. The next part of the planning stage is the making of the proposal. Making of the proposal or presenting of the proposal to the hospital administration and also proposal to the health directorate of the city that has been chosen to establish the program. So what does a good proposal should contain? So here are the following questions that must be answered in writing the proposal for an oncology outreach program. First one is, are there underserved population in the program area? If this yes, where are they located? So for the information of everyone, the hospital have established 3 outreach sites. It's in Alhasa, Hafar Albaten, and Katif. What are the main barriers to oncology services for these populations? Basically, for Hafar Albaten and Alhasa, it's the geographical distance. The distance is like Alhasa will reach 2 hours before you get to the mom, while Hafar Albaten is 5 hours to 6 hours drive. Is there a lack of access to oncology services? Yes, because in the areas mentioned, at the time in 2017, there are no cancer care hospital. That's why most of the referrals are being sent to the mom to be attended to. Is there a lack of trained providers to offer oncology services for this population? Yes, that's why cases are referred to us in the MAM. So an oncology outreach program is possibly an effective way to address these barriers. It's a resounding yes. And with this guide of questions, we managed to make a proposal for the administration and for the health directorate of the certain cities. So next phase is the identification of resources under planning. Is there available trained staff? Yes, there are in King Fahad Damam. There are oncologists, hematologists, physicians, nurses, and pharmacists, and of course, the clinical nurse coordinators, well-trained and highly competent. Training of allocated outreach site clinical staff, it has been planned and arranged by the Director of Oncology Center, together with the Chairman of the Oncology Outreach Program, with the Health Directorate of the Alhassa, let's say, city, that their healthcare workers will be trained in the MUM for a month or two, exposed to the ambulatory area and to the inpatient ward. Pharmacists will be exposed in the pharmacy area, so on and so forth, to get that competency developed with them before, during the transition, and to be of assistance when the team from the MUM sets in there to start to initiate the program. Next is, what is the method of transportation? At this case, all the three sites, Alhassa in particular, by land. Bus, car, or van, driver is provided by the hospital to transport medication and staff to the outreach facility site. And cost-effective analysis. Definitely, this is one of the factor that has to be looked at by the host, King Fahad Damam Hospital, and also by the outreach site. So if they agree, it's not only with this hospital that the cost-effectiveness analysis comes in. Also put into consideration the patients and the family's financial requirement on this. So instead of traveling from Alhassa, 2 hours drive going to the MUM, they will just be driving 10 to 15 minutes because we are bringing in the service to them on their community. And the last phase under planning would be the building good rapport and relationship through collaborative meetings with the key stakeholders, administration of the hospital and the outreach facility, and even the health directorate. So under KFSHD, here are the key stakeholders, initiated, of course, by the director of the Oncology Center and assisted by the chairman of the Oncology Outreach Program, with the different chairman of the different services under oncology, the program director for the nursing oncology, and the different allied healthcare representative, pharmacy, laboratory, even mailing services, and of course, the finance department. This is an example of one of the meetings held by the key stakeholders during the time to iron out the moving of Alhassa Outreach Program from King Fahad Hufuf to Prince Saud bin Jalawi. So Dr. Hani Al-Hashmi, the director of the Oncology Center at that period, together with Dr. Fahad bin Shamsa, Mrs. Isabel Rose for the program director of oncology nursing, and the rest of the staff and the key stakeholders that plays their own role on this outreach program. Next phase is the development of action plan, and we have already identified that Al-Hufuf in Al-Hassa will be an outreach site. The doctor will visit there once a month initially and check on it, how it goes, would it make it more frequent. Who is with the hematology physician going to the outreach site, and that would be the outreach program coordinator and the driver on the initial phase. What are the types of training that will be held, and how many trainings. So we are speaking of the nurses that will be assisting there in the outreach clinic, and if the laboratory or the pharmacy has also to be cross trained here in the MOM. The supply of medications and the follow-up and the continuity of care activities in the outreach site. So the last phase would be the implementation. Now that we have chosen Alhassa as the outreach city, the hospital that has been chosen is King Fahad Al Hufuf Hospital, located in Alhassa. The dates that has been agreed upon is last Thursday of the month, and the staff initially that are going there on back in 2017 is the hematology doctor and the outreach program coordinator, the driver, and the other healthcare workers will be like the nursing and the laboratory radiologist technician. It will be coming from the outreach facility area. So the outreach program coordinator have created this monitoring plan just to see how does the program is going on, like collecting of data, statistics, the number of patients availing these services, and patient satisfaction, any complaints, and even the number of patients coming back from the outreach, going back to the MOM. And lastly, there should be a continuous progress meeting with a specific outreach program site partner. This is to ensure the smoothness of the program and discuss any problems or challenges that has been encountered. And lastly, to continuously provide refresher course and updates to the healthcare provider. This is the process that has been applied in Alhassa Outreach Program back in 2017. The hematology physician will review the list of patients 3 days before the clinic visit. The outreach program coordinator, he's working more of the admin part. He's the one who will inform the patient by telephone of their clinic schedule and their time. They will go to the King Fahad Hufuf Hospital Clinic. And this outreach program coordinator will also pick up the laboratory tubes from the laboratory phlebotomy area and the TKI or other oral chemotherapy medication that will be delivered on the same day of the outreach clinic. On the day of the clinic visit, the hematology physician will see these patients in King Fahad Hufuf Hospital. He will be assisted by a nurse trained in the MOM, but a nurse from the outreach facility. Then any laboratory that will be done, if it is routine, can be carried out by the laboratory department there. But for any special tests, let's say BCR-ABL or PML-RARAP or APL or myeloma markers, the tubes were brought by the outreach program coordinator. Blood will be extracted by the laboratory technician, and it will be sent back in the afternoon to the MOM so that the test will be run and it will also be saved in the system. Then the physician, most of the time, will now call the clinical nurse coordinator for assistance regarding the laboratory results, radiology, any imaging or procedure results that has been not reviewed. What do I mean by that? Back on those days, the electronic file is not yet fully implemented. So the file, the hard copy file sometimes is not complete and you have to compare it with the hospital informatics system. So this is what now will drag the clinical nurse coordinator during the clinic visit, as the doctor will have a constant communication with you, either by phone call or you will be replying, sending him the pictures of the results to, to be explained to the patient. Then, on the last part of the process, after the clinic visit, the physician will decide if the patient will continue following up in the outreach clinic or if there will be changes in the clinical condition of the patient that he has to be sent back to the mom. And if the patient will continue in the outreach, what are the necessary tests for the next visit, and he will write on the documentation that will be placed in the shadow file. Now, this shadow file will be safe kept by the outreach program coordinator, and a copy of it will be placed on the patient hard file in the medical record in the mom. And the OPC will also arrange the next visit of the patient as ordered by the visiting physician in outreach clinic. This is the healthcare facility initially used in Al-Hassa, King Fahad Hospital, Al-Hufuf. In the outbreak of the COVID pandemic, the initial process is needed to be revised because of the ongoing lockdowns of cities. Patients are not allowed to enter another city, and imagine, I have mentioned that the barrier initially are the geographical location of our patient. So, this is the new process. The hematology physician in the clinic or in the ward will hand over the patient case to the outreach physician. This physician is under the outreach facility, and it's Prince Saud bin Jalawi. Our physician name is Dr. Naima Al-Musailem. She is a brilliant physician who was a fellow in KFSHD and now a consultant in Prince Saud bin Jalawi. The clinic doctor or the ward doctor from the mom will hand over clinic follow-up, any treatment plan, chemotherapy, ward discharge plan, even those patients for transplant that undergoing outpatient mobilization can be also followed up there for the pilgrastim injection and even the laboratory IV and oral chemotherapy treatment. This time we're giving intravenous treatment in Prince Saud bin Jalawi, laboratory tests, and surveillance of lymphoma patients. Now, after the physician had made the handover to the physician in outreach, the clinic and ward nurse has to inform the clinical nurse coordinator that this patient will be transferred to the outreach service so that the continuity of care will not be disrupted. And the responsible person, which is the lead coordinator of that disease, has to be aware where the patient is already following up. On the other hand, if a patient will continue the treatment like a chemotherapy has been ordered by the clinic physician or the ward, the clinic nurse has to hand over the pertinent documents related to the treatment to the outreach program coordinator, who is also changed from an admin staff to a nursing staff. When the patient is seen or receive a treatment in the Al-Hassa outreach program, any changes, anything discussed will be also relayed by the outreach physician to the clinical nurse coordinator for any new findings and any required care of patient. The clinical nurse coordinator in Tamam is the one now going to prepare the laboratory tubes or get an appointment for a PET CT scan or any other radiology test imaging that is not available in Prince Saud bin Jalawi. Now, also the coordinator need to assist if there are any requirement for documentations or chemotherapy protocol that is required by the outreach physician in Al-Hassa. If the patient have any changes or in his clinical condition, the physician in the outreach has to discuss it with the main responsible physician in the mom, and also the CNC has to be informed to transfer back the patient to the care under the mom. The CNC will be the one arranging the appointments in the clinic or
the admission. And the CNC will also inform the patient of their new schedule. This is Prince Saud bin Jalawi, a secondary hospital. So in Prince Saud bin Jalawi, they managed to provide for the outreach at least 3 clinics, 1 oncology, 1 hematology, and 1 for pizza oncology, an even treatment room, 10 beds for adult, 4 beds for pediatric, and 1 procedure room, and even 1 recovery room consists of 2 beds. So this is the clinic room in Prince Saud bin Jalawi, the treatment room, the procedure, and the recovery room. And this is the outcome since March 2020 until December 2021 for the Al-Hasa Outreach Service. This is combined with medical oncology and hematology adult. On 2020, the clinic visits that the outreach observed is 2,019, and on 2021, it jumped to 3,840 clinic visits. On the other hand, for the treatment, these are a combination of chemotherapy and supported treatment like blood transfusion or electrolyte replacement. From 2020, it was 2,504, and it also jumped to 3,007 on the end of 2021. The conclusion on this presentation is that Oncology Outreach Program has bilateral benefit for KFSHD and the community hospital, but the big winner here is actually the oncology center patients and their families. Patients' trust to their local community hospital has been restored and even boosted. Quality of life has been enhanced among the patients and their families. Local healthcare practitioners more exposure to take care of oncology patients, which in turn develop their skills, with their competence, and they become more confident in cancer care. And every healthcare provider have a special role in the outreach program, but nurses are the backbone of this program. They care not only for the patients and their families, and also for their colleagues. I would like to acknowledge the following staff, those in the task force and the current hematology outreach team. This is their usual day in Al-Hasa Outreach Clinic when they were accepting the patient. And this is our physician, Dr. Naima Al-Masailem, how they check on the chemotherapy medication and when they give it to the ambulatory patient who will receive the treatment. And this is, of course, the MRPs on the mom side and the coordinators under hematology. Special thanks to Dr. Hani Al-Hashmi, the former director of KFSHD. During his term, the Oncology Outreach Program has been initiated. And to quote Dr. Hani, hematology clinical nurse coordinators are the glue that holds a patient's healthcare journey together in the adult hematology and HSCT department across the entire patient experience, and wherever there is someone in need of care, CNCs work tirelessly to identify and assist with the needs of the patients and their families. If there will be any questions regarding this presentation, I will be happy to accommodate them after this session. Thank you very much.
Thank you for the talk, Ms. Annalise Stanislao. In King Fahad Specialist Hospital in Damam, we continuously find ways to cater to our always growing number of hematology and oncology patients. We will proceed to the next talk. We will be having no more discussions due to time constraints. We will proceed with the fourth speaker.
So our fourth speaker, Professor Eugenia Tricos Arjona, graduated with the university, degree in nursing from National Education in Spain. She cared on her specialty in pediatric. And then she finished master's degree in of nursing, both from university. Further, she obtained master's degree in hematopoietic stem cell transplant. And currently, she is an associate professor, Faculty of Nursing and Pediatry University. Also, she working in oncology and transplant units in hospital university. And also she is a joint accreditation committee inspector. So welcome, Professor Eugenia. The mic is yours.
Good morning. First of all, I would like to say thanks for your very kind invitation. And I am going to talk about the mineral leaf donor because yesterday and today we have been talking so much about the patient and about the donors, but we have to think about that the donors are healthy people and they need some care also. Okay, the learning objectives are how we choose the best donor, the donor source and donor selection, and talking about apheresis in low-weight donors, risks and challenge, and also about donor advocate and informed consent. In this paper from the EBMT, we state a few things. The first thing and important thing is the bone marrow has been the source for hematopoietic stem cell transplant collection for more than 40 years. Since 1990, of the use of mobilized peripheral blood stem cell has been increasing, but between 1999 and 2002, the pediatric patient undergoing transplantation from any donor received source, first of all, for bone marrow, 64%, 30% of peripheral blood stem cell, and 6% for umbilical cord blood. But autologous transplants are always performed from peripheral blood stem cells in pediatric population. We have to be aware, like EBMT estimation, 600 and 700 children in Europe become transplant donors from their sibling every year. It's quite a lot of children. And how we choose the best donor? HL-matched siblings are considered to be the best donor for both practical and biological reasons. Among pediatric patients undergoing transplant, 70% receive healthy stem cells from a brother or a sister. Worldwide, data demonstrate that more than 1/3 of children undergoing allogeneic transplantation receive graft from siblings under the age of 18. Keep on talking about the donor assessment. According to the Joint Accreditation Committee, International Society for Cellular Therapy and EBMT rules, our donor has to have a donor medical history collection and also a physical examination, blood sample testing within 30 days before bone marrow or peripheral blood stem cell collection, and also performance status assessed at the hospital admission and discharge. We have to use the Lansky or Kartoffel score, and full blood counts checked before the first harvest procedure and after stem cell collection. You know, sometimes it's needed more than one collection. Sometimes we need 2 or sometimes 3 times. If we talk about the source, bone marrow from an HLA identical sibling donor is considered the standard of care worldwide for children undergoing hematopoietic stem cell transplantation. Although, as I said before, the use of peripheral blood stem cell among these donors is increasing. Like the Center of International Blood and Marrow Transplantation Research data reports that patients younger than 20 years undergoing allogeneic transplant, the main source from any donor was 51% was bone marrow, but followed by 70% the peripheral blood stem cell, and 22% are umbilical cord blood. But more pediatric patients receive bone marrow than peripheral blood stem cell, irrespective of the donor type. But why? Because it's explained by the higher incidence of non-malignant conditions and the higher risk for chronic graft-versus-host disease with peripheral blood and stem cell source. Here is the slide. In this slide, we can show how the bone marrow is the more commonly used than peripheral blood in pediatric patients receiving hematopoietic cell transplant from non-related donor. So, bone marrow is harvested under general or epidural anesthesia from posterior iliac crest. Depending on the hemoglobin concentration, the harvested for bone marrow volume and the hemodynamic stability of the donor, allogeneic blood transfusion could be given during or after the procedure. After the harvest, intravenous analgesic could be needed sometime. But if we talk about peripheral stem cell donation, this peripheral blood stem cell collection is performed after mobilization with a granulocyte colony stimulating factor, which is administered subcutaneously. And we have to think about that we are always talking about a child that is not ill and he has to get some injection that he has never seen before. That is neither once or twice a day for 4 days. So, I don't know what happened. And leukapheresis was usually performed on the morning of day 5 using an automatic continuously flow cell separator. We need a peripheral vein access or RCBC placement and 1 or 2 additional days. In this paper from the Spanish hospital from Madrid, they talk about the collection of extremely low weight infant, that is infant that with low than 10 kilos. We need a vascular access, a central venous catheter with 5 or 7 French, of course with double lumens. It should be placed in femoral vein after mild sedation. The device has been priming with, for patient, is priming with red blood cell cross-matched, irradiated and leukocyte depleted, but for donor is priming with 4% albumin solution. The adverse that they report has been the mobilization. They have 2 cases of low-grade fever. During the leukapheresis, they report hypovolemic signs, hypotension, pallor and diaphoresis, nausea related to citrate effects, but they don't need any transfusion. As to healthy donors, they have adverse events. So, talking about the risk assessment, we have to think that the bone marrow and peripheral blood stem cell donation are considered safe procedures. The medical procedures necessary to obtain stem cells from donors are not without any risk. And think that a donor is a person, no matter how small it is. few things to think about. The GSCSF is safe for minor healthy donor, and also we are not risk for central catheter placement. A priming apheresis device with red blood cells. And another thing, we have a correct assessment of the pain, and we have to think also about ethical consideration. We don't have to forget that the procedure of peripheral blood stem cell collection in children carry the risk of pain related to the GCSF administration, the risk associated with the central venous catheter placement, and also the occurrence of hypocalcemia during apheresis, and the risk of cardiovascular problems. The GCSF causes temporary discomfort in a minority of younger donors, muscle and bone pain, headache, abdominal pain. None of the early complications described in adults has been reported in children. The long-term effects in healthy children have not been reported, and no report on increased risk of cancer. But if we talk about the CVC placement, younger children would need apheresis catheter placement, of course, with its attendant risk is pain, hemorrhage, arterial puncture, pneumothorax sometimes. We have to avoid the adverse event. It's necessary sometimes mild sedation. We need a training team for this. And sometimes it's done in interventional radiologists. And they place the central line, but ultrasound technique. We need a central line with double lumen with an acceptable blood draw. And what about pain assessment? We need tool and scale in order to assess the pain for this child. It's difficult to assess the pain in small donors, but mostly reported by parents and observation during procedure. Talking about the bone marrow harvest, the most frequent complication was pain, requiring administration of analgesic. Pain was reported at the collection site, including lumbar stiffness. And about collection-related pain, related to the CVC placement during and after collection, sometimes persists for a median of 3 hours or more, and requiring non-narcotic analgesic administration for a median of at least 1 day. And we have also some ethical issue. We have to think that the long-term data have confirmed that the donation procedure is safe, but substantial psychological and social stress is involved in the process of donation to a family member. HLI tipping process among siblings of transplant patients can cause feeling of ambivalence and sometimes distress. Admitting sibling donor may feel proud because they are chosen for being the donor for his brother or sister, but they are immunological compatible and therefore able to be a donor, but anxious about the hospital procedure. The transplant center deals with 2 pediatric patients, the recipient and the donor, and a situation that may lead to conflict. More about simple principles. First, do no harm. A pediatric donor of transplant can almost always safely donate with parental consent and greatly benefit the recipient and their families. But also siblings may feel pressure from family members or medical staff to become a donor. advocacy, and case for medical review to protect them from situations when their psychological or medical health may be at risk. And we don't have to HLI typing when potential family sibling donors have medical or psychological reason not to donate. The major criteria for family members' minor donation are lack of a medical equivalent adult relative able to donate, presence of a strong positive relationship between the donor and the recipient. It is likely that the recipient will benefit from the transplantation, but we have to reduce the donor risk, clinical and emotional, to a minimum. We have to say that the parental consent at the child assent. And when a minor sibling are identified as potential donor, there should be significant efforts to protect children from the stress and the responsibility involved in the donation process. The JC standard says that a donor advocate shall be available to represent allogenic donors who are minors or who are mentally incapacitated, and those terms are defined as applicable law. The key issue that must be addressed with childhood hematopoietic cell donors is their initial inability to understand and voluntarily consent. I am running out of time? Okay, I will finish quickly. As JC standard said, with a donor who is a minor, it is appropriate to discuss the donation procedure with the pediatric donor in terms that he or she are able to understand. And assent should be also obtained in an age-appropriate manner. And some psychological issues. The donor experienced a wide range of complex emotional response, positive and negative, whereas the parents' response were mainly positive and less complex. The effect on this intense experience of stem cell transplant has a long-term impact on the whole family, indicating the need for follow-up and psychosocial support. Some psychosocial issues and some emotional reaction could be fear and concern regarding the donation, but need to be involved. Feeling of no choice and pressure to donate, but also behavioral problems and anxiety. More psychological issues could be being a stem cell donor can be a stressful experience for pediatric siblings and can potentially lead to the development of long-term distress response. Difficulties include trouble sleeping, behavior problems, low self-confidence, depression, problem at school. Siblings of pediatric cancer patients in general experience considerable stress, and that stem cell donor may be at higher risk of distress. Younger siblings tend to experience a low self-esteem, anxiety and depression, and adolescent siblings tend to experience family conflicts, less family cohesion, and anger that increase with age. And what is the role of the nurses? The competency and skill that have value to the nursing profession are the evidence, basis, and practice, empathic communication, and other broad range skills such as critical thinking. Nurses have successfully taken the role of improving communication for donor mobilization, collection, and liaising with the staff of the procession facility. Most authors describe the necessity of educational information sessions for both pediatric donors and parents, and some therapeutic follow-up sessions. We can address the need for information about potential complications. A tour of the hospital sometimes is needed, and introduction to staff to allow donors to be familiar themselves with the hospital environment. And more nurses-led research is needed. And now, few conclusions. We have to avoid donor psychological harm, rather than predicting whether donation will result in a psychological benefit to the donor. Following the standard operating procedure for JC standard contribute to unified criteria and safety in the whole process. Commitment with a healthy donor safety, best practice for CBC placement, and no allotransfusion, please. Peripheral blood stem cell collection is a safe procedure for healthy donor and patient. And some recommendations that have been performed by training team. Few ideas to take home. Worldwide, children under the age of 18 years are not allowed to donate hematopoietic stem cell transplant for unrelated recipients. Thus, bone marrow and peripheral blood stem cell donation are considered safe procedures. The medical procedures necessary to obtain stem cells from donors are not without risk. And previous research has found that the HLA tipping process among siblings of stem cell transplant patients can cause feeling of ambivalence and distress. And sibling donors may feel proud if they are immunologically compatible and therefore able to be a donor, but anxious about the hospital procedure. And thanks.
Eugenia. So,
Thank you. We shall have a quick lunch and prayers. We should be back at 1 o'clock.
Welcome back to the last session of the equations. So currently, myself, Mohammed Bashir from King Saud University Medical City, and Mr. Usama Yunus, a nurse manager in adult hematology and bone marrow transplant, Minister of National Guard Affairs, Jeddah, is here with me. So it's my pleasure that he will introduce the first speaker. So, Mr. Usama, the floor is for you.
Thank you very much. Good afternoon, everyone. Welcome to our third session. I'll introduce the first speaker, Ms. Suha Al-Khraysat, graduated with a Bachelor of Science in Nursing from the University of Jordan, Amman. Currently, she is an adult stem cell transplant nurse coordinator in adult hematology and oncology ward, King Abdulaziz Medical City, Ministry of National Guard Health Affairs. She is effective in pharmacological and non-pharmacological management and treatment of various disorders and diseases, in the development of nursing care plans, as well as in the improvement of patient care.
Thank you so much for the nice presentation.
Yes, she will be giving a speak about reducing ATG infusion-related reaction by increasing the infusion duration in adult stem cell transplant recipients, a single institution experience from Saudi Arabia. Ms. Suha, the floor is yours.
Thank you so much. I will talk today about our practice and our new protocol in NGHA Riyadh. And I will try to be fast because I know we are short of time. So the first thing, our project, our objective, it will be summarize the principle for the use of ATG, allogenic stem cell transplant, and we will discuss the most common side effect of the ATG infusion, and we will talk about our new practice and the guidelines to minimize the IRS related to ATG, and also we will tell you our outcome of our new ATG infusion practice. Introduction, the first thing we will talk about the ATG. ATG is the polyclonal immunoglobulin that affects the human T lymphocyte and has been used for adequate plastic anemia, and also we use it for prevention of the GVHD and even treated of the GVHD for allostem cell transplant. As we said, the ATG is an antibody preparation derived from the rabbit or horse hyperimmunized with a human thrombocyte. And the ATG is so important in vivo T cell depletion strategy, which is reducing the graft versus host disease in HLA match or mismatch donor allografting. Uses of the ATG, as we said, treatment of GVHD, and also prevention of the graft versus host disease, pre or post stem cell transplant medication. It will be suppress the donor T cell to minimize the recognitions of the host cell as foreign. And also we give it as part of the conditioning, which is to prevent the rejection component of the conditioning regimen, and it will be eradicate the host T cell to allow acceptance of donor cell. ATG infusion, as you know, always, ATG infusion has the reaction. It doesn't matter whatever you run it, it will have a reaction. It can be mild, it can be moderate, and it can be severe. The most common, actually, side effect, fever, chills, hypotension, hypertension, tachycardia, and there is nothing well documented the strategy. The labels is saying to you to give as a pre-medication, antihistamine, acetaminophen, and corticosteroid, and will tell you run it over 6 to 8 hours. But usually, most of the time, if you run it as what the label said, even when you are giving the pre-medication, it will be end with the reaction, and sometimes it will be, as we said, moderate or severe, which leads to interruption for the treatment or discontinuation. This is the most side effect. I put this schedule just to see the percentage, how it is high. The fever, more than 63% patients, they will encounter fever. chills, leukopenia, pain, headache, abdomen pain, diarrhea, hypertension, nausea, thrombocytopenia, peripheral edema, dyspnea, all the side effects like anaphylactic sometimes. Infusion of ATG, it's challenges, and it's a significant number of patients can have reaction. As we said, it can lead to discontinuations or delay of the therapy in some. The symptoms and signs of infusion reaction can lead to an additional investigation. As we said, 63%, most of the patients, they will have fever. Of course, if you have a fever patient, you will go directly to investigate the reason why he has a fever. You will looking for the etiology, infectious etiology. Then you will give as IV antibiotic as empirical, which is costly. This is will more cost. In addition, pre-medication, as we said, acetaminophen, antihistamine, and steroid has been used to decrease the risk of reaction. And as we said, the labels is saying the first infusion over 6 hours, and then over 4 hours for subsequent infusion as tolerated. However, these measures reactions still occur, highlighted that need for another structures. In our study, we found one abstract. He was evaluated the rate of infusion reaction. From 2004 till 2012, they were finding it's increasing the reaction. It's reached 93% between 2010 till 2012. And most these patients, even they was pre-medicated, they require another doses of steroids. So the ATG, as we said, is given mostly in stem cell, is part of the conditioning, as we said, to prevent GVHD. Such as reaction can lead to undesirable treatment interruption and the reduced patient satisfaction. And there is reported an incident more than 90% reaction with standard infusion time. Even measures to reduce the reaction are needed. There was so clear we need to investigate to optimize the administration method, as such reactions are associated with morbidity and increased healthcare associated costs. As we said, ATG is part of condition. You cannot stop the conditioning. This will be destroy all or the treatment plan. So what is our strategy? To migrate such reaction is to prolong the infusion time. There is a very few reported has been published using this strategy. Reported on their experience after changing the infusion protocol of ATG over 20 hours instead of 4 to 6 hours. However, it was very limited because the number of the patient, it was only 28. So in our institution, the ATG was infused over 6 hours. This was 2011 till 2015. When we noticed each patient, single patient, he has a reaction. So we have to sit and find another solution, how to reduce the reaction. We report our experience and outcome of the people, of the patient receiving standard or prolonged infusion time, and discuss the possible predicate for such reactions. Actually, our experience, the new experience, our new protocol, we already posted as a poster in 2020 in nursing, EBMT, and even one of my consultants, he was also he presented our experience in 2021 in EHA, and the last one is our hematology journal. One of our consultants also, he posted our experience. So this is the method of how we improve the ATG or to decrease the ATG reaction. We said all this is physician, IBR approval, it was from the physician, pharmacist, nursing, and the quality. Patients that underwent stem cell transplant from 2011 to 2020, and they received ATG were included. It's 74 patients, actually. From 2011 till 2015, the ATG was infused over 6 hours while from 2016 till 2020, ATG was infused over 24 hours. We are splitting the dose in 2 bags. Each dose was running over 12 hours. This is, as we said, our infusion protocol. ATG, we changed it to be infused over 24 hours, 2 bags, over 12 hours. And all the patients will receive as pre-medication every 6 hours, acetaminophen and antihistamine and corticosteroid and steroid, which is طبعا plus we wrote as a PRN in case of reaction. We evaluate the infusion reaction associated with the use of ATG in the 2 populations. We make it as one group 6 to 12 hours and the other group for 24 hours. Reaction occurs in all patients receive the standard infusion with over 50% considered moderate to severe, which lead to premature discontinuation of infusion in a high proportion of the patients. As we said, you see from over 6 to 12 hours, most of the patients, they have reaction. 50% of them moderate to severe. And you will see, I will show you the table, how many percentage we already stopped the treatment and or delay the treatment or reducing the dose. In this prolonged infusion group only, which is 24 hours, we have only 29% develop reaction. And it's only actually 1 patient, which is 2%, it was moderate to severe. Nearly half of the patients require urgent evaluation for their reaction by critical care response team, and 27% require ICU admission. We are here talking about the standard, which is 6 hours. Okay, so the patients, we have 27 of them activated CCRT, and 27% they require actually ICU. Comparing to the long duration, which is 24 hours, it's only 2% require CCRT and 0 required ICU admission, respectively with the wrong infusion. Having higher ALC before the infusion was associated with a significant risk of an infusion reaction. Actually, which is the absolute lymphocyte count. This is when we our data. We found this, but this now we are working on this to know what is the rule, why if they have acute lymphocyte, they have more evidence to have reaction. So patient receive infusion has significantly high number of any infusion reaction as well as a moderate to severe. Activation critical care and transfer to ICU unit was significantly higher in the short infusion group. Interruption or discontinuation of ATG infusion also significantly more frequent in the short infusion time. Time of neutrophils and platelet re-engraftment, as well as indicate of cytomegalovirus reaction require pre-empative therapy, was the similar. Because we look for all the variables, we even check if it will be effect on their engraftment or if they will have more infectious like CMV infection. In multivariable analysis for the infusion reaction, the only thing, as we said, the acute lymphocyte count was predicted within more than 5.9. So this need more work on that. As we see, you see our characters in our analysis data. It was a diagnosis, what is their diagnosis, the ECOG, the conditioning regimen, the TBI, if even the type of the donor, the stem cell source, and the ALC. If you see, here you will find it. The standard dose, but actually our number of the patient, it was 74. 11 patients was 6 hours and 63 was 24 hours. First of all, why it's just different numbers? Because actually we expand our service after 2015, because that you will find it's more longer, bigger number for 24 hours infusion. And actually we decided that in beginning in 2015, we changed our practice for 24 hours. If you see more, the age, actually, we took the medium age 20, but for the prolonged, it was because more patients, we in higher in this study, 36 patients, 35 patients. The malignant disease also, it's 41 in prolonged, and the standard infusion only 4. Non-malignant 7, which is mostly, we use it, as we said, for aplastic anemia, and in the prolonged, 22. ECOG 1, and 0 in the prolonged infusion. The one, even the stem cell also make CRAN TBI, as we said. Look to the reaction, this. For standard infusion, we mean 6 to 12 hours. From the 11 patient was reacted. So we have 100% patient reacted. But in the prolonged infusion, from the 63 patients, only we have 18 patients. So it was 29% only reacted. Moderate to severe reaction, in standard infusion time, it's 6 from 11. That means 55%. But in the prolonged infusion, we have only 1 patient, which is 2%. CCRT activation, 5 patients was activate CCRT. But in the prolonged infusion, it's only 1 patient, who is the same patient who has moderate to severe, which actually this patient, he has like chest fungal infection because that he was really deteriorated more with the ATG infusion. The ICU transfer, it was 3 patients required to transfer to ICU, but in a prolonged infusion, we have 0 patients transferred to ICU related to ATG infusion reaction. ATG held 7 patients from 11. That means 64 patients was held. Some of them for a few hours. Sometimes we delay for the next day. But in the prolonged infusion, it was only 8, which is 13%, and it was because the nurses was misunderstood. They just hold it when they found the patient. He had like chills and rigors. But nowadays, since 2020 till 2022, actually, we have only 1 patient was reacted. But from 2020 to 2022, we have never really have any, we don't encounter any reaction. And ATG discontinuation, as we said, 5% from the 11, that means 45, it's a big number. But from prolonged infusion, it's only 3 and 5 of the 5%. Time of the ANC engraftment, as we said earlier, it doesn't make any difference. 19% from the standard infusion, prolonged infusion 14. That means it doesn't affect on the engraftment time. CMV activation also, again, the same thing, because that means ATG, it doesn't affect on that. Our conclusion of this, we found it prolonged the ATG infusion, timely significant, decrease the reaction, which is leading to lower treatment, interruption, or discontinuation. Importantly, severe reaction or the need for critical care service was almost not seen in the long infusion group permitted smooth administration of the conditioning regimen. Reaction were also independently increased with the higher ALC, level. These observations were not further validation. Consciousness-based recommendation by experts. This is in general and all over the world, even in PMT. It was thinking the infusion of rabbits, ATG was published. The decrease of reaction, pre-medication with steroid and antihistamine, acetaminophen are recommended. And in addition, prolong the infusion more than 12 hours was highly recommended. Our colleague in pediatric, they ran in 18 to
So I will be sharing our experiences for autologous hematopoietic stem cell transplantation in Hodgkin lymphoma. Just to sum up, this population from the mom, this is from our hospital. So from 2006 until 2019, we have like a high, or like how many percentage? From 2006 to 2007, it's like 100% already increasing. Imagine from 2006 to 2019, we have like 17,036 accumulative statistic from 2006. And then, by the way, this distribution of cases in Eastern Province, because as you can see, Saudi Arabia, and the yellow one, Eastern Province. It's a large mass for the Saudi Arabia. Catering with different town proper, like Al-Hassa, Daharan, Damam, Hapar al-Batin, and other provinces. Al-Hassa is leading to 27%. That's why outreach program was created from our side. And during that time as well, we are not catering only the Eastern Province. We are catering different provinces or different regions. We have patients from Al-Jub, Ha'il, Jizan, Medina, and even Riyadh. So in the cases of, in our institution in 2020, the leading cancer patient is breast cancer. Hodgkin lymphoma or the non-Hodgkin lymphoma is on the top 4. And imagine with our oncology center from 2020 to 2021, the new cancer cases increment 17%. Imagine with that. And that new cancer cases, we have like 85% is cancer, and the 15% is the non-cancer cases. Just an overview. From 2010 to 2020, we started on October 10, 2010 with 2 patients. This is a multiple myeloma patients. I am one of the apheresis nurse who collected with that patient. So now I am a clinical nurse coordinator. So I am just encouraging nurses that given an opportunity, it's always like a door. So wherever you are, just don't lose hope that, for example, that you are in a certain area and you are given an open door to be in a specialized area, grab it, learn from it, and be good on it. So from 2010 to 2020, as you can see our trend, it goes up. The blue one is for our autologous, and the red bar is for the allogenic. So that's it. So it's increasing. Next. Autologous stem cell transplantation has a lot of indication. From our institution, we catered multiple myeloma, lymphomas, non-Hodgkin and Hodgkin lymphoma. We also have leukemia, APL, multiple sclerosis. We have one case of 1 ITP, and now we have a GCT. We are just awaiting for a sequential transplant for our GCT patient. The plan is to do at least three transplants for this patient. So he is due to have the second transplant by second week of June. On this manner, because I am the lymphoma coordinator of our institution, I'll be focusing on the lymphomas now. Total of non-Hodgkin lymphoma is 71, and Hodgkin lymphoma is 78. From the Hodgkin lymphoma, I'll be getting the outpatient and the inpatient. And then Our total stem cell transplant done from 2010 until this moment is 311 patients. So out of that Hodgkin lymphoma, non-Hodgkin lymphoma, we have 149 patients, 94 male and 55 female. And Hodgkin lymphoma, as I have told you a while ago, it's like 78 for the Hodgkin lymphoma and 71 for the non-Hodgkin lymphoma. Just a brief introduction. Autologous stem cell transplant, we will start with auto, means from him or from herself. So it's a process where the patient uses the stem cell to replenish the bone marrow cells which is destroyed by the chemotherapy. So primarily, the stem cell that we're going to give to the patient, it will be like a seed that will help the bone marrow to grow again. So this is a process. Sorry, we'll go back on that one. This is the process. This is the patient. Patient will be giving a mobilization. It's either chemotherapy plus GCSF or GCSF alone. During the stem cell mobilization, we will be in lymphoma, on day 12 or day 13, we will check the CD34 of the patients. If the level is more than 20, we will do collection. So the apheresis team will do the collection. After the collection, the stem cell lab will do the processing. And during the processing, before the cryopreservation, they will be using DMSO. The DMSO is a cryoprotectant in order for the cells, in order not to crystallize, that will infiltrate or will puncture the cells. So that would be for the cryopreservation, and they are giving like 10% out of the volume. For example, you have a 200 ml of volume of the cells, so it will be like 10% of it, you will have like 2 ml only. And then after that, for the reinfusion, for the lymphoma patient, we have this evaluation post the salvage chemotherapy. We will be re-evaluating the patient via the PET scan. And then after that, we will bring the patient in the lymphoma tumor board for the discussion. And I'm always hoping for my patient that during the salvage of the chemotherapy that were mobilized by the patient, that they will be like chemosensitive in order for them to go through the transplant. So this is the Hodgkin lymphoma. Hodgkin lymphoma is a type of cancer cells that affects the lymphatic system. Lymphatic system is one of the soldier inside our body who is fighting from the infection. So when your white blood cells, called the lymphocytes, goes out of control, go anywhere and like that, those lymph nodes will be enlarged. And then that would be like one of the symptoms of Hodgkin lymphoma, aside from the other B symptoms. We are using Ann Arbor staging system for Hodgkin disease and Hodgkin lymphoma. Just think, above the diaphragm, that is stage 1 and 2. Below the diaphragm, it is stage 3 and 4. As you can see here, the Hodgkin lymphoma, this is the normal cells under the microscopic level. So the red Sternberg cells, that is the hallmark of the Hodgkin lymphoma. It consists of 1 or more or 2 or more nucleated cells. Now, question. Nurses, is autologous stem cell transplant feasible in outpatient? Yes. With all the improvements of the supportive care, and also the conditioning regimen that we are using, we will not be using it like 24 hours infusion, it is feasible. So what are the benefits of autologous stem cell transplant in outpatient? Nurses? If you're doing a transplant in outpatient, what are the main benefits for the patients? Come on. Convenience, okay? How about the others? How about when it comes to the infection? When risk of infection. So, for a shorter hospitalization, you will see that our patient will be having a minimal exposure for nosocomial infection, right? And also, cost effectiveness. If the patient is admitted for how many, like 14 to 21 days, versus the 12 days or in the outpatient that you will be seeing the patient, as a whole, you will see the differences already when it comes to the costing. So our aim for our Hodgkin lymphoma is to evaluate the feasibilities of autologous stem cell transplant. As I have said, I already laid down the questions a while ago. So what are the eligibility criteria? Psychosocial evaluation. Most of the patients going to transplants, we are having a workup. We are asking our other discipline, other departments like social worker, psychologist, even dietitian, dental, patient compliance. Compliance of the patient is really a big question mark because there are patients who will say yes, and in the middle of the transplant, they will say no. Which, even if they signed already the consent, they have the right to stop or not to continue. This is another eligibility criteria that we need to be focused when it comes to the autologous outpatient. Caregiver availability. Because there are patients who would say that, okay, I have a caregiver who will be with me, but at the end of the day, they will say, no, it's my friend is not available. Or sometimes they're bringing friends. They're not even bringing their relatives. The informed consent. So of course, as a nurses, the hospital with the standard protocol, we need to secure the signed consents. So in our methods, we have 25 patients out of 78 patients, 14 male and 11 female, with a median age of 27 years old, ranging from 21 to 52 years old. Our study, the pre-transplant supportive care, the mobilization, the stem cell collection, conditioning regimen, and the graft infusion, we are doing it with allocated place. We call it C5, short stay unit. We have specific nurses who are allocated also with this. They are highly competent in handling patients. We are giving our prophylaxis medication on day -2. We are using single agent melphalan 200 milligrams per meter square. How is melphalan be given? How are we going to give melphalan? Can you tell me? How many minutes is it? Ranging for how many minutes? Melphalan, we are giving it for 15, sometimes 10 to 15 minutes. GCSF, we are giving it on day +5 until the neutrophils will be recovered. And of course, the patient will be evaluated daily in our outpatient clinic. So as I have mentioned, our patient is 25. And then with that 25 patient, we use salvage chemotherapy of a median of 3 cycles, including the conditioning regimen ranging from 1 to 6. We have a lot of salvage chemotherapy that we are using with our Hodgkin lymphoma. We are using cisplatin base, DHAP, DICEP, ISHAP, plus or minus rituximab, plus or minus brentuximab, vedotin, plus or minus nivolumab. The conditioning regimen that we are using, as I have told you, melphalan 200 milligrams per meter square, unless the patient is having a problem with a cardiac issue. We are giving 140 milligram per meter square. And the CD34 that we are using for our patient, that we infused, there is a median of 8.03, ranging from 3.4 to 15.8 million stem cell dose. The criteria for admission, of course, if you're having a fever, maybe something is cooking, we need to inform the doctor. Nausea and vomiting and diarrhea, mucositis, and toxicity of grade 3. So our result is that the median recovery of the ANC will be like 11, ranging from 9 to 14 days. Platelet with 20,000 is like 11 also, from 9 to 18 days. Admission, we have 14 patients out of 25. 7 patients would have like febrile neutropenia, and the other develop grade 3 toxicity. The median hospitalization day is 4 days out of range of 3 to 16. And the median time of admission is on day plus 6, ranging from day plus 1 and day plus 12. One of our patients has a contraction with a lung infection, that's why. With a day plus 1, we admitted the patient. And the median follow-up is 36 months, ranging from 2 to 58 months. Alhamdulillah, 24 out of 25, 96% are alive, and 92% is disease-free. There were no treatment-related deaths. On day plus 30 and day plus 100, there's no mortality in the outpatient. Conclusion, outpatient transplant now, you can agree with me. It is feasible, it is safe, and it is cost-effective. And the outpatient offers lower risk of infection, decreased waiting time for the transplant, significant cost saving, and improved patient satisfaction and quality of life. Just to sum up this nursing role of and the nursing challenges. So I will not go through with it, especially with the central line and wavering compliance of the patient. That is the most of it. This is one of my favorite slides. Clinical nurse coordinator from our institution, we are dealing our patient as a new and from the end of life. During the transplant, from the induction, mobilization, stem cell collection, conditioning regimen, infusion, and then, but you need to think, with this time, sometimes there are patients who died and patients engrafted and with a happy life like that. So our C5 short stay unit will be the one monitoring the patients, doing all the workup. I just want to acknowledge my doctors who helped me with this presentation. Dr. John, Dr. Panyotis, Dr. Abdulillah, Dr. Majid, Dr. Muhammad Zahir, and Ate Ann, Miss Ann Istanislao, who encouraged me always to do some presentation, which is really, this is one of my phobias, so bear with me. So this is the transplant team. So we cannot do anything alone. So the transplant has a lot of members. The medical team, nurses, clinical coordinators, C5, laboratory, and everything. So this is my references, our doctors and consultants, coordinators, our clinic, our nurse.
Thank you very much for your informative presentation. I'll introduce the next speaker, Ms. Sandra. Bern University of Applied Sciences. She also participated in a number of volunteering work in various international conferences, and she has been active in a number of research publications and presentations. The floor is yours, and welcome in SSBMT.
Thank you very much for this introducing words, and I try to share my screen with you. Okay.
We cannot hear you.
Welcome. Oh, you can't hear me.
The volume is very low.
Is it better now? Is it better with you now?
Yeah, it's better now. Excuse me, you have 20 minutes to complete your presentation.
Yes.
Thank you.
I do my best. Okay. Welcome to my presentation about prophylactic medications. And I would like to say that I have no disclosures to declare. And I jump over this slide as I have already been introduced to the audience. And I would like to give you a short overview about my presentation. I give you a short introduction, then I will talk about side effects of chemotherapy. Then I would like to show you some risk factors for GVHD and infections, and the principles of prophylaxis in GVHD and infections and the nursing implications. The photos that you see within my presentations are made by myself. They are from the ward where I've been worked before. So why do patients with stem cell transplantation need prophylaxis? They get high-dose chemotherapy for conditioning before transplantation, and the chemotherapy can be myeloablative, for example, with a combination of busulfan, cyclophosphamide, and melphalan, or non-myeloablative when we combine fludarabine, cyclophosphamide, and ATG. And the third version is reduced intensity chemotherapy for patients who are at high risk for developing complications, and they get, for example, a combination of fludarabine and busulfan. But what is really important is that these patients have a prolonged phase of immunosuppression, especially after allogeneic stem cell transplantation. And of course, these patients have a risk of graft versus host disease. So we have to look more in detail to these patients and look what we can do for them. So what are side effects of mucositis? What are side effects that can come? One of them are mucositis of the GI tract, and possible signs and symptoms are here: the oral infections, oral ulcerations, taste changes, bleedings, pain, osteonecrosis, and diarrhea. And I would like to make a further attention to these three side effects because they are really they bring a high complication rate for the patients. So how can the side effects occur to the patients? They can be acute or chronic, so they can really come very fast and soon, or more delayed. And they come with the destruction of cells, and they are not the malignant cells affected by the destruction of the cells, but also the rapidly dividing healthy cells. And they are most frequently affected the marrow cells, of course, the hair follicles, the mucosal lining of the GI tract and the skin, and the fertility and germinal cells. And here I would like to hint mostly on the mucosal lining of the GI tract and skin, because here we have the high side effect of infections that can occur to the patients. So how is the risk for infections in detail? I can say that 90% of the patients after high-dose chemotherapy and stem cell transplantations are affected by infections, and often it is a fever of unknown origin. And patients at the highest risk are those patients with an expected neutropenia phase with less than 500 neutrophils for at least 8 days or longer. And the most common infections are, when we look to the bacterial infections, invasive pneumococcal infections, clostridial and difficile infections. Looking to the viral infections, there are the CMV infection, the EBV infection, the varicella zoster virus infection, and the herpes simplex virus. And last but not least, there are also fungal infections like pneumocystis, Diero-Vecchi pneumonia, PJP infections, molds, mucocutaneous candidiasis of the mouth, yeast infections of the skin, and some more. But these are the most common ones. So what I think is important to look when do the infections most commonly come, and the phase is of stem cell transplantation and the occurrence of infections is divided into 3 phases. There's the pre-engraftment, then the post-engraftment phase, and the late phase. And when you look down on the slide, you see below the picture the days, day 0. The pre-engraftment is mostly from day 0 to day 15, and then the post-engraftment phase is between about day 50 to 45, and then we have a delayed time starting at day 100 about. And in the pre-engraftment phase, we have a neutropenia and the barrier breakdown due to the chemotherapy, as the mucositis appears most often in this time, and we have the central venous access devices during this phase, as we need them for the chemotherapy and the stem cell transplantation. So there we have the highest risk for infections, and you see it also here on this slide that there are various infections possible and which come down in phase 2, but there the patients are still at a high risk because they have an impaired cellular and humoral immunity, and the NK cells recovers at first, and but the CD8 T cells numbers increasing, but they are restricted to the T cell repertoire. They are not so various as before transplantation, and some patients have a delay and recover slowly, maybe due to GVHD or other affections that I think they have. So I have mentioned the GVHD. What is, why can patients develop a GVHD? What is required for that? So the graft, the stem cells that are transplanted, they must contain immunocompetent cells that can work within the host. And the host must possess alloantigens that can be recognized as foreign by the immunocompetent cells of the graft. And the host must be unable to mount an appropriate immune response against the graft. So it's a quite complex phenomenon that comes up to the GVHD, but when I read these requirements, it was quite, for me, I could understand it better when I read it some years or some time ago. It's more easier then. So what are the risk factors for developing a GVHD? There must be or can be HLA disparity, an increasing degree of HLA mismatching. The older age of patients is a high risk factor. Then the use of female donors for male patients. To my experience, I can see that females are not preferred for donoring stem cells due to the pregnancies, because then women develop more antigens. And the alloimmunization of the patient, of the donors, for example, due to pregnancies or prior infections. Then the nature of the GvHD prophylaxis, what has been applied to the patients for GvHD prophylaxis. Then the increasing donor age also, and the increasing intensity of the preparative regimen and the use of peripheral blood stem cells as opposed to bone marrow cells. Then the seropositivity for CMV of the patients. So let's have a look on the principles of GvHD prophylaxis. We can, on one side, have an interference with the host immune response. There we have a reduction of the immune response, and here we apply a combination of calcineurin inhibitor with an anti-metabolite, for example, cyclosporin A combined with methotrexate. Or we can hint on a T-cell depletion, shortly, or the abbreviation is TCD, and there we can make it ex vivo, where there we have various methods, for example, a CD34 plus selection, or the removal of specific T-cell subtypes, or we can make it in vivo. There we apply anti-thymocyte globulins, the ATG, that is common, I think, to all of you when you're working in the practice with stem cell transplantation. So now let's have a look on the principles of early infection prophylaxis. There we should look for limiting unnecessary antibiotic exposures, then optimize antimicrobial therapies, for example, applying empirical approach when we have to escalate the antibiotics, and we have to look for catheter-related, central line associated bloodstream infections. There we have to look for sterile insertion of central venous catheters by a specialized team. Then we should avoid the femoral insertion of CVCs, as they have a higher risk for developing infections. And we should do the CVC cleaning with chlorhexidine during the use of the CVC, and remove all unnecessary catheters as soon as possible. And we have to perform regular oral care. And when we look to the catheters that are necessary, we have to look on individual problems, because we should remove the catheters as soon as possible. But when we have patients with really bad veins where we can't take the blood, we have to look for further options that we maybe can use to get the blood samples for the follow-up. So what are nursing implications? Not complications, they are nursing implications. We should frequently monitor the patients in view of vital signs and their general condition. And please pay attention to even subtle changes and address them, because it can change really fast, that the patient is in the morning really well, and in the evening the patient is already at the ICU because the situation is unstable. And in case of any infections, please have a look on monitoring the patients, intensify the monitoring, ensure the fluid balance, because they have fever and lose lots of fluids during the fever phases. and identify and monitor potential infection sites. And there have a look on the catheters that the patient has, then the mental status, signs of any bleedings, the pain, and the general appearance of well-being. Then let's have a look on key principles in oral care. There it's really important to perform an accurate assessment of the oral cavity and perform an individualized plan of care if possible, and initiate timely preventive measures and correct treatment. There, I would like to go more in depth and would look for prevention of oral mucositis. And that's really, really important to educate and encourage the self-reporting of any oral changes, even if they are really small, these changes. But we have to look on them. And we have to look for good and regular oral hygiene, including gargling to remove any unwanted debris. Then we should encourage the patients for interdental cleaning. Then we should use fluoride toothpaste, foam, gel, and trays. Maybe also sodium chloride water or salt water rinsing. And maybe apply early nutrition interventions that doesn't appear a malnutrition that interferes with the wound healing, and maybe apply cryotherapy and sucking ice chips during malformation infusions. And I can tell from my experience that we have in each patient room at the lavabo where the patient is washing himself and makes the oral hygiene, we have a plan what the patient should do, when, and which things he should apply. And we have it in 3 languages. As Switzerland speaks German, French, and Italian, and we have for each language 1 paper that we can make it in the mother language of the patient, that the patient can always look what should be applied when. So an oral care assessment should include a pre-existing dental problems that should be assessed, appropriate treatments should be assessed. Older patients and females are at higher risk for oral damage. There we should have a look. Then we should look on the history of alcohol and or tobacco use. Then poor nutrition and hydration. Supportive feeding is really important, and the supportive therapies during any problematic phases like opiates, diuretics, sedatives, and oxygen therapy, which can cause drynesses. And then we should use clinical tools like a good light source, gloves, a tongue depressor, and dry gauze. And then we should make the patient in a convenient and comfortable position so he can look into the oral cavity, and we should use valid and reliable assessment instruments which are easy to interpret and which are really usable in your clinic. And then we should evaluate the oral sites, so we have the whole oral cavity where we should look like the cheeks, the lips, the soft palate, the floor of the mouth, and the tongue. And then consider oral rinses and mucosal protectants like barrier rinses that are licensed as a preventive measure and to reduce pain. Then we should perform an anti-infective prophylaxis. Maybe polypheramine is helpful for the patient, and or if possible the low-level laser therapy. So last but not least, I would like to have a short look on the mild or moderate oral mucositis, what we should do then. Patients should be supported to continue the oral care even when there are small damages of the oral mucositis to prevent more infections. And the recommendation is that the frequency of oral rinsing may be increased if possible, as our aim is to keep the oral surfaces clean and moist. Then we have to check frequently for oral infections, swab and treat appropriately them. We should apply antifungal treatments, local or systematic, like it is required. Consider mucosal protectants and adjust the food intake according to the comfort of the patients. And if possible or if needed, we should monitor the patients in view of swallowing problems, malnutrition and weight loss. And if needed, we should use artificial nutrition to avoid malnutrition. And we should assess the fluid intake and route of administration of pain relief regularly. And we should apply an adequate pain management to the patients as it is really painful for them.
Sorry, we have 1 minute left.
I'm 2 sentences and I'm finished.
Okay.
And we should educate our patients in view of reporting us any changes. So here are my references for the presentation. And thank you very much for giving me the opportunity to talk here, and I wish you a pleasant day. Thank you very much.
Thank you very much, Sandra, for your elegant presentation. Now we go to our next speaker. Our next join us virtually to give us her perspective regarding mobilization in stem cell donor and the basic and point of attention. So, Charlotte, the floor is for you.
Can you hear me?
Yes, we cannot see you currently.
Okay.
Yes, it's okay.
Yes, so I'm going to talk a little bit more about mobilization and stem cell donors, basically the basics and also point of attentions for nurses. So thank you for the kind introduction. I can skip mine now because you already know I'm a registered nurse specialized in oncology and hematology. I work for the University Hospital in Ghent, in Belgium. I have no conflicts of interest. So what is mobilization of hematopoietic stem cells? That's the main question. So maybe first, what is a hematopoietic stem cell? It's actually the human's body's raw material. So if you can see the pictures, if you see it on the left side, you see a lot of little stem cells going to school. They have career day and the teacher tells them they can be whatever they want. So that is actually what stem cells are. They have the capacity to differentiate and multiply into all types of blood cells, and they are situated in the bone marrow, the hematopoietic stem cells in the red bone marrow. What is the purpose of mobilization? So the goal of mobilization is actually a peripheral blood stem cell collection. And the goal of that collection is, of course, stem cell transplantation. In 1985, so that's not a long time ago, the first clinical attempts of trafficking hematopoietic stem cells into the peripheral bloodstream were made. Before that, so before the use of growth factors, the harvesting of hematopoietic cells went through bone marrow harvest. The biggest advantage of collecting stem cells through peripheral bloodstream is that you don't have the general anesthesia that you have with bone marrow harvest. On the other side, with bone marrow harvest, you don't need to use the growth factors. So you don't have the complications of the use of growth factors. Another advantage is that if you collect stem cells through peripheral bloodstream, you have a faster engraftment of your stem cells. So this is a little recap of what I already told. So you have the bone marrow, but the stem cells that are in the bone marrow have to go to the peripheral bloodstream. And that we can do by the use of the growth factors. Then about the mobilization. We have two types of donors. First of all, autologous donors. There the donor is the patient. We have two types of mobilization: without chemotherapy, that we call à blanc, or with chemotherapy. So the without chemotherapy part, there we start the growth factors 5 days before the first scheduled day of apheresis. The dose of the growth factors is actually always the same, so 10 microgram per kilogram body weight per day. We have no CD34 count. What is CD34? The other speaker already told it. It's actually stem cells express the cell surface marker antigen CD34. So if we do count in a blood draw of the CD34, we already more or less know if we will be able to do the apheresis, yes or no. So with an à blanc, so no chemotherapy, there is no CD34 count the day before apheresis, only at the first day of apheresis. A little point of attention there, with referred patients, the day that they come for the CD34 count is mostly the first day that they come into our hospital. So if you don't have that, then the first day of apheresis is the first day they come. So maybe it's a good idea to call them before they visit your hospital to give a little bit more explanation about where they have to go, how late, the logistic stuff. Which pre-count do we need to start an apheresis? That's 15 or more CD34 per microliter. And here you see the currently approved growth factors for mobilization in hematopoietic stem cells in Europe. The with chemotherapy part, so some people receive chemotherapy before they have the stem cell collection. Then the growth factors start not 5 days, but 9 days before first scheduled date of apheresis. That's because due to the chemotherapy, our patients go into aplasia. The dose is the same, of course. There is a CD34 count the day before apheresis. The most used chemotherapies and mobilization are RDAP, RCHOP, RCHUP, and RICE, but also high-dose cyclophosphamide, for example, in multiple myeloma patients. Some hospitals like to use it, others not, because it has a lot of side effects, especially located in the kidneys. So what is the role of the chemotherapeutic agents in mobilization? And there are two roles. So first of all, it's a stimulus for mobilizing hematopoietic cells to the peripheral blood, so from the bone marrow to the peripheral bloodstream. And in multiple myeloma patient, it also has an anti-myeloma effect. Then the use of plerixafor and pore mobilizers. First of all, what is a pore mobilizer? Risks to be a pore mobilizer is increased age. So how older you are, the more risk you have to be a pore mobilizer. Prior treatments and cycles. So the more treatments or cycles, the more risk you have to be a pore mobilizer. Also extensive disease burden or prior use of thalidomide. And of course, if you have evidence of poor marrow function. Plerixafor, also known as Mozobil, is shown to improve CD34 cells collection in combination with the growth factors. So what do we call a successful apheresis? When we have a minimum of 2 times 10 to the 6th per kilogram for a single transplantation and 4 times 10 to the 6th per kilogram for a tandem transplantation, so double transplantation, or patients that are younger than 65 years old. Most of the time that are multiple myeloma patients for the double transplant. How do we do the calculation? So we get the CD34 count from the lab. We do that times the volume that we collected, divided by the body weight of the patient, divided by 1,000. And then we have our CD34 count times 10 to the 6 per kilogram. So then we know if we have enough. So the minimum is 2 or 4 for a double transplantation. Be aware that the stem cells for autologous stem cell transplantation are cryopreserved, so we have to take into account the loss of stem cells during that freezing procedure. So what do we choose, whether or without chemotherapy? Of course, that decision is always made by the medical team, but here we have a few examples. So the disease itself, then the treatment that is given, because some chemotherapies work more mobilizing than others. Of course, as mentioned before, the previous lines of therapy, if a patient already has a lot of lines, already received a lot of lines of therapy, then it's possible that we choose to do a collection à blanc, so without additional chemotherapy. A little side note there, for the collection of donor lymphocytes or T cells, we don't have a mobilization procedure. Then the second type of donor is an allogenic donor. Then we have two types of allogenic donors, so an MRD, so matched related donor, first line sisters and brothers, second line mother or father. Then we also have the MUT donors, so the matched unrelated donors. They can be found in a donor bank worldwide. So I'm going to take advantage of this situation to encourage everyone to register as a stem cell donor, because in my work experience, I can say that it could save lives. The procedure of mobilization is actually similar to the process of an autologous à blanc collection, because, of course, we will not give chemotherapy to a healthy donor. So also 5-day mobilization, the dose is also the same. No CD34 count at the day before apheresis, and the pre-count minimum is also 15 or more. What is here successful apheresis? If we have a minimum of 5 times 10 to the 6 per kilogram. The calculation is the same, but pay attention, here you have to use the body weight of the patient and not of the donor. Normally, these cells are administered fresh, but due to COVID measurements like high infection rates and transportation issues, we still ask to cryopreserve the allogenic stem cells. What are the possible side effects of mobilization? The bone pain of the growth factors, because the stem cells want to go from the bone marrow to the peripheral bloodstream. So they actually press against the bone. That's why you have, can you experience bone pain? Of course, you can have paracetamol for that. And also the feeling of having a little fever. Then the collection, most common are dizziness and tingling during the collection time, pain or bleeding at the insertion point of the needle, and of course fatigue, so being very, very tired. Contraindications, so if the donor is known with a known allergy of the growth factors, if there are side effects after the previous use of growth factors, and of course pregnancy or breastfeeding. In allogenic donors, I'm going to tell a little bit more about that later in the presentation, but take in mind that there is a great importance in prior donor assessment. Little point of attention there, don't forget the psychological effects when you can't be a donor. So if you can be a donor for your sister or brother, we have to take that into account. Donor education, so our doctors and or nurses and myself, of course, explain to the donor how an apheresis procedure works, what the possible side effects are, how to store, prepare, and give the growth factor injections. Point of attention there, very important. The donor and patient's information is strictly separated, even if it are brother and sister. The importance of screening and follow-up. So for screening, the main question is this a suitable donor? How do we check that? A good anamnesis, that's actually the key. So we check the medication list, the medical history. We have a very long medical questionnaire. And of course, also prior to the donation, we do a blood draw. In that blood sample, also the infectious disease markers are tested. Take into account that you have to notify your donor if you test, for example, for HIV virus. And then, of course, the importance of a detailed information session before the donor gives his or her consent. That's very, very important. The follow-up, that's actually the last part of my talk here. So after a week, in our hospital, it is after a week, the donors come back to see if the blood levels are stabilized after the apheresis. That's actually the main thing that we do to see if the donor is okay after the apheresis. And then, of course, we have a long-term follow-up as well. After a few months, after a year, and then every year, we go and check with the donor, take in mind the psychological effects. For example, patients with MS who have to undergo a stem cell transplantation never received chemotherapy before. So this will be the first time. So as a nurse, you have to be very alert for that. And also, as I mentioned before, if a brother or sister or parent can't donate for their child or brother sister because they are not suitable, take into account the psychological effects of that. So as you can see, there is a very, very important role for the nurse practitioner, the nurse specialist, or the coordinating nurse. Thank you so much for your attention and having me, and have a good end of the day. Thank you.
Thank you very much for your nice presentation. We are going now to our next speaker, Dr. Zinaida Perek. She's a hematologist at the University Hospital Center Zagreb and assistant professor at the School of Medicine. Immunobiology of a graft host disease and the role of gut microbiota in the pathogenesis of intestinal GVHD. Her clinical interests focus on acute leukemias and infectious and long-term complications after allogeneic stem cell transplantation. Dr. Perek is the chair of Transplant Complications Working Party and co-leader of all subcommittees, Acute Leukemia Working Party of the European Group of Blood and Marrow Transplantation, EBMT. She will be talking about supportive care in GVHD. Dr. Perek, the floor is yours. Sorry, we cannot hear you, Dr. Perek.
Okay, and now?
Yeah, thank you.
Okay, yeah, the same problem happened yesterday. Thank you so much for the kind introduction, and thank you very much for the invitation. I'm very happy to be a part of the Nurses Conference part as well, especially on a topic that I think is very significant, and that is supportive care in GVHD. I have no relevant disclosures, and I will try to address all aspects of supportive care in GVHD, so prevention of infections, nutrition, local therapy, physical therapy, and finally psychosocial therapy. To begin with, I would like to highlight that ancillary therapy and supportive care are central components in the long-term management of chronic GVHD after stem cell transplantation. Also they are directed at organ-specific control of symptoms or complications resulting from GVHD and its therapy. The importance of supportive care is highlighted by the fact that one of the NIH consensus documents, one of 6, is actually dedicated the whole to supportive and ancillary care. And we know that these NIH documents are the main documents in the management of GVHD. I will start with prevention of infections because the main reason most patients with GVHD die actually is unfortunately infectious complications, and this is related to the use of systemic immunosuppression, and patients who have systemic immunosuppression at 1 year after stem cell transplantation actually have lower survival, and for that reason for us physicians it is very important to try to treat patients with at least immunosuppression as possible, and also to prevent infections as much as possible as well. For that reason, these patients need long-term surveillance for CMV, prophylaxis for herpes virus, antibiotic prophylaxis, and this has to be continued 6 months after systemic treatment, for example, steroids or cyclosporin has been stopped, not like in usual patients without GVHD where we stop at 6 months after transplant. Also, these patients, especially the ones on steroids, need to be reintroduced with posaconazole, so for prevention of invasive mucosis, because patients who do get this prophylaxis have really less invasive mucosis, and we know that this is a very dangerous complication. And also they need to be vaccinated as early as possible, so not as we thought earlier, and we didn't vaccinate them as long as they are on the systemic immunosuppression. Today we advise that they are vaccinated as early as possible. I wanted to share a case, a patient case with you, because this is my patient and I think it really highlights the importance of supportive care. This is a patient who was 30 years old at stem cell transplantation and who had myelofibrosis. This is important because it was a patient who actually was outpatient and wasn't hospitalized before stem cell transplantation, which of course makes it more difficult no matter how much we talk to our patients. And she had pretty, I would say, normal talk with a normal course of complications with acute GVHD developing at day 60, which needed systemic steroids. But she had so many side effects of steroids, including diabetes, that we had to stop and taper off and stop steroids really quickly. We did that at day 100. And shortly after she came back to me, she was my patient with a red eye and red mouth. At that time, I was a younger physician, and I presented her to my seniors, and everybody was pretty sure it's after day 100, after cessation of immunosuppression, it has to be chronic GVHD. Unfortunately, at that time, we had already a multidisciplinary GVHD team established, so a team of many different organ specialists. As we know that chronic GVHD is a multisystemic disorder which can affect literally any organ. And she was first seen by an ophthalmologist, a neural medicine specialist, because these were her main problems. And they were totally agreed on one thing, and that is that this was not GVHD, but actually something completely opposite, an infection with herpes virus, which was of course something that we treat completely the opposite, with decreasing immunosuppression, unlike GVHD where we would reintroduce immunosuppression. When I say that senior physicians made a mistake, it's not their fault, because actually this is how GVHD of the eye and herpes simplex look like infections. So it's a red eye, and to a transplant physician, it is not clear without a special tool like it is to an ophthalmologist what is actually inside. And how important is to then have an ophthalmologist in the team can help you understand if you see the photo of, and this is taken with my patient's permission, of how the course was really dramatic of the infection, even though we were treating her in the right way. And can you imagine what would have happened if we didn't? My first point here is that multidisciplinary approach is essential. Multidisciplinary team for GVHD is essential because, first of all, at the first step, it improves diagnostics of GVHD. I will continue with nutrition in GVHD, and here we intuitively know that nutrition is important. We have guidelines on nutritional support in stem cell transplant recipients, but this is pretty much scarce. Enteral nutrition is recommended over parenteral, safe food handling over neutropenic diet as well, but I don't know how you do it, but in many institutions still parenteral nutrition, neutropenic diet take place because all the level of recommendations are not high, as well as for acute GVHD, where still many centers stop oral intake if patients have high volumes of diarrhea, even though the level of evidence is pretty low. In chronic GVHD, malnutrition reflects severity of GVHD, and therefore you have to treat GVHD to manage malnutrition, and this is also something that has to be managed by a multidisciplinary approach, including a gastroenterologist and nutritional medicine specialist. What I wanted to mention here is not only macronutrients, but micronutrients as well. I can't mention all of them, but I wanted to mention vitamin D, because vitamin D is something that we know that has some immunological properties, and it really has in GVHD. Low levels of vitamin D before transplant really consistently show an association with chronic GVHD. As you can see here, this is the curve with patients with lower levels of vitamin D before transplant. And also patients who receive vitamin D for vitamin D deficiency and have steroid refractory GVHD, in some cases we have seen significant improvements that we attribute to vitamin D as well. This has actually enabled prospective studies of supplementing vitamin D in stem cell transplantation starting before transplantation, day -3. And these studies have really shown that supplementing vitamin D decreases the incidence of chronic GVHD. What about other aspects? Well, here I wanted to mention prebiotics because it has traditionally been said to our patients that prebiotics shouldn't be used. However, in recent times, we have learned about the role of healthy intestinal microbiota in stem cell transplant recipients, the role of disrupted microbiota, which happens because of conditioning, because of GVHD, in GVHD and in stem cell transplant outcomes. And it has really become interesting to preserve the healthy microbiota, which can be done with prebiotics, probiotics, and postbiotics. And I will here focus on prebiotics because there are studies which show that giving prebiotics, for example, to patients before transplant can really help preserve healthy microbiota. This is indirectly seen by production of butyrate, which is produced by anaerobic bacteria, which are the healthy microbiota, and patients who get this actually have higher levels of production of butyrate. Also, it seems that giving prebiotics to patients can actually prevent acute graft versus host disease, and these are really early studies, but it remains to be seen how this can be used in real life, and it is also included in nutrition. This is then my second point, and this is what I already said, that we need multidisciplinary approach to improve treatment of GVHD as well. So nutritionists, gastroenterologists, they're all a part of the multidisciplinary team. When it comes to local therapy for GVHD, this is also very important, especially it works in organs which are most frequently affected by GVHD, so oral, skin, and eye GVHD. And this is from the same document on supportive care that I've mentioned earlier and that I recommend reading. So you see that this is really comprehensive. There are lots of possibilities, and therefore, again, not possible to manage these patients without different organ specialists who know these treatments happens best. Also, in these many of these cases, you can actually increase local therapy and prevent the increase of systemic therapy, which I said at the beginning is the goal of all our physicians. Back to my patients. A patient, she did recover from that horrible infection that I've shown to you, but unfortunately, at about 9 months after transplantation, she had gradual deterioration of her vision, and this time she was seen again by an ophthalmologist who was sure this time that this is chronic GVHD and pretty severe chronic GVHD of the eye, which is not strange because it was in the territory of previous infection. She started topical therapy, although with signs of mild GVHD at that time, she also had indication for systemic treatment. However, she didn't want to use steroids because she related steroids to her previous infection, and I couldn't say that this is not true. But local therapy, the one we had available, so autologous eye drops and cyclosporin drops, were not improving the situation, and this led to ulcerations. And I have to remind you that severe eye GVHD can even cause perforations of cornea. So this is something really, really serious. So as I said, oral changes as well. But her main problems were the eyes, and this is the time point where our ophthalmologists remembered that we can try something else in her, and this is something that is already used in ophthalmology. It's called amniotic membrane transplantation, so it's a fetal membrane taken at cesarean sections, and it's used in ophthalmology in severe burns, infections of the eye. It is easy to administer because it has no HLA antigen, so you can give it without immunosuppression. And he thought that it could be something new for our patient where she didn't want systemic immunosuppression. This is how it is used. It is actually thawed and sutured to the eye, where it dissolves over a week or two. And this is how impressive it looks in our patient, even macroscopically. And it really improved, healed her GVHD and had a prolonged effect. This is because amniotic membrane is rich in cytokines, in fibroblasts, which promotes healing and has an immunosuppressive effect. So far, we have used it in 10 patients and pediatric as well, and we are continuing this approach, which is a completely novel approach in IGVHD. One other thing I wanted to mention is potential of local therapy in mild GVHD, and this is something that is called autologous platelet gel that promotes healing in similar way as amniotic membrane. It has been used in wounds, and in my experience, we have used it in 5 patients, and at least this is the thing that we have published. We have used it afterwards as well, and you can see how impressive this can work in severe ulcers of the mouth. In our patients, we saw partial to complete responses, but what is very important, we had improved oral intake and quality of life of our patients. This is then my third point, and this is that multidisciplinary approach, working physical therapy in GVHD. I have to remind you that physical recovery is very slow in our patients. They come back to pre-transplant levels at 1 year after transplant, but need several years to come to the level of general population. And if they have GVHD, that happens even much slower. Also, every chemotherapy can cause something that we call fatigue, and that's something that occurs in cancer patients, and they feel tired as long as 10 years after transplantation and after chemotherapy, which of course makes them rest. Inactivity leads to loss of muscles, and muscles are lost due to GVHD and steroids as well, and this is then a vicious circle that leads to more inactivity and more fatigue. It is very important to tell our patients that it's not that they should not rest, but it's the contrary. They actually need physical exercise, because there are studies, and this is one of them, showing in a randomized way that patients who exercise before, during, and after transplant, in comparison to the ones who don't, have really more endurance, more strength, less fatigue, and better quality of life. But it's not only about physical exercise, it is also about physical therapy, because beside physical exercise, there's something which you all know, it's physical and occupational therapy. And although there are no controlled trials, there are some case reports and case series which say that multi-component rehabilitation helps especially patients with sclerotic chronic chronic GVHD. There are recommendations, but optimal timing and schedule is unknown. And although early intervention traditionally is more effective, we have to be careful here because intense physical activity can actually trigger fibrosis, induce inflammation and trigger fibrosis in these patients. But this is where a multidisciplinary approach is extremely important because you have physical therapy specialists, occupational therapy specialists. Patients with sclerosis sometimes have difficulties opening their mouth, speaking, eating as well. And this is in systemic sclerosis, but physiotherapy intervention and home exercise can really be effective in reducing those symptoms, therefore in GVHD as well. Also, occupational therapy can help because there are some home and work adaptation measures which you can do in kitchen, bathrooms, household in general, which can really help ease their life of our patients with sclerosis and improve their quality of life. Therefore, multidisciplinary approach can improve physical functioning of GVHD patients as well. Finally, last but not the least, when it comes to psychosocial therapy, we have to keep in mind that patients with moderate and severe chronic GVHD, and these are scales according to the severity of GVHD, have lower quality of life as GVHD has higher grade, lower physical functioning, lower mental functioning, lower social functioning. These patients are more likely to take medications, and what is very important, many of them are actually unable to go back to work. Therefore, it is important that we know that there are options for them as well. They're called behavioral interventions, and they can be provided even by online or telehealth modalities. This is something that has really risen in the era of COVID. And this is the US example of a study where these patients are handled online, where problems are identified, and then these problem-solving treatments are introduced usually by telephone. And this has really shown to improve depression and improve the stress in our patients. So there are options for them as well. Psychologists and psychiatrists is also important, and multidisciplinary approach like this can improve emotional well-being of GVHD patients as well. So in conclusion, I think I have persuaded you that optimal GVHD management means multidisciplinary management. So it's not only transplant physicians, it is many other different specialists. And I can assure you that when you have a multidisciplinary team like I have in my institution, nurse coordinator is the key person in this optimal GVHD management, because nurse coordinator is the one who schedules all the appointments, connects all the specialists to transplant physicians, to patients, also educates patients, and is actually crucial for all these improvements and for the improvement of quality of life of GVHD patients. So with this, I thank you, and I thank my GVHD multidisciplinary team in Zagreb.
Any question?
Inshallah, hopefully. Yeah, let's go. Any question? I think if there's no question, let me throw one question to Jennifer. Jennifer, with her experience in apheresis, currently in our area we have challenges regarding this apheresis line. So we used to put peripheral line as well as put palm card for collection. So is there any way thereby we can make a one line which can be useful for both collection as well as for the apheresis, as well as for the transplant?
Okay, when it comes to the line, we are using temporary dialysis line for adult, French 11,
You can use it also for the stem cell infusion. If it's, for example, it's a multiple myeloma, back-to-back fresh transplant, you can use the line. In our approach, during the stem cell mobilization, we are putting the line to collect. But if it's as I have said, if it's a fresh back-to-back, we are using same line for the supportive treatment for the patient. So did I answer your question?
Yes, thank you very much.
Sure.
Any further question? So.
Well, thank you very, very much. What an amazing set of talks we've had today. I feel really privileged to be here and to be able to offer you some closing remarks, and I think you'll all agree that the programme today has been incredible and extremely informative. Of course, the beauty of coming together like this is that we create a really rich learning environment together and create, through our collaboration and sharing of our experiences, that very environment. Before you leave today, please complete your evaluations. It's extremely important that we know what we did well this year and what we can include for the meeting next year, as well as what you'd like to see more of in this nurses programme. We'll be 10 years next year, so that will be also a moment to celebrate. So I want to take a final moment to thank SSBMT and President Professor Ahmed Alaska and Miss Annalie Estanslu of the nurses for creating this opportunity for us to be here together. To the SSBMT and the EBMT teams as well as the organising team, in particular Ms. Noor. Thank you also for the IT support that we've had the last couple of days, and thank you all for attending. We hope to be together again next year. Thank you.
Before we leave, can you come up to the stage for picture? For picture, yes. Sabine, yeah. Also. Thank you.